ourselves to the WHO global strategy, which is to reduce physical inactivity by 10% worldwide.
This is something that we hope that we can impart to all attendants here.
Penuaan adalah proses semula jadi. Akan tetapi, penuaan haruslah dihadapi secara sihat dan tidak menjadi beban kepada orang lain. Menjadi seorang warga emas yang sihat tidak semestinya bebas daripada sebarang penyakit. Warga emas yang sihat sepatutnya dilihat sebagai seorang yang mempunyai kualiti hidup yang baik. Seseorang haruslah mampu berdikari dan mampu untuk bergerak dengan sendiri. Untuk mencapai kualiti hidup seperti berikut, kita seharusnya bersenam dengan kerap di samping menjaga pemakanan. Saya adalah seorang yang kerap bersenam dan nasihat saya kepada yang sedang menuju ke arah status warga emas adalah untuk memastikan senaman itu dijadikan sebahagian daripada rutin seharian untuk mengelakkan pengecutan otot dan mengekalkan stamina.
Tun, berapa kali Tun bersenam dalam satu minggu?
Saya kalau boleh itu tiap-tiap hari lah. Tapi tak ada masa, kadang-kadang 2 hari sekali, 3 hari sekali.
Tun, bagaimana Tun cari masa untuk bersenam apabila Tun tidak berada di rumah ataupun masa Tun berjalan?
Masa kita berjalan ke tempat lain, sukar untuk kita teruskan rutin kita. Tetapi ada cara-cara lain. Umpamanya kalau kita boleh berjalan, kita berjalan sedikit. Dalam rumah pun boleh. Dalam rumah pun saya biasa berjalan sehingga 6 round di atas beranda. Itu mencukupi bagi saya.
Adakah Tun melakukan latihan berbadan?
Weight ada. Saya guna dumbbell. Dumbbell angkat sikit. Tapi weight yang berat tidaklah.
Pengerang mempunyai hampir 100,000 penduduk dan 90% daripada mereka adalah masyarakat Felda dan kampung tradisi. Kebanyakan mereka adalah tergolong daripada warga tua berumur melebihi 50 tahun. Pada tahun 2020, dianggarkan bahawa penduduk Malaysia yang berumur lebih dari 65 tahun adalah sebanyak 7%. Malaysia ketika ini menghadapi prospek penuaan penduduk dan data statistik terbaru meramalkan ini akan berlaku seawal tahun 2030. Kita perlu bersiap sedia untuk memenuhi tuntutan dan cabaran penduduk kita yang semakin tua. Kebanyakan golongan warga tua ini mempunyai tahap kesihatan yang kurang baik serta ada di kalangan mereka yang menghidapi pelbagai penyakit tidak berjangkit NCD seperti kolesterol tinggi, kencing manis, darah tinggi, sakit jantung dan berat badan berlebihan. Ada juga yang menghidapi penyakit kronik seperti strok dan lumpuh. Justru, untuk mengatasi masalah yang ada seperti kurangnya pengasuh profesional, perawatan yang berpatutan dan perumahan yang mesra orang tua, terutama di kawasan luar bandar, satu program latihan perawatan kesihatan rumah yang juga dikenali sebagai program penuaan aktif telah dijalankan untuk melatih ahli keluarga atau sukarelawan kaedah yang tepat untuk menolong warga tua. Pusat penuaan aktif dengan kerjasama rakan aktif Parlimen Pengerang yang dipengerusikan oleh YB Datuk Sri Azalina Osman Said adalah sebuah pusat latihan minda kepala dan tubuh difokuskan pada golongan warga tua yang berusia 60 tahun ke atas untuk mempertingkatkan kualiti hidup mereka. Pusat penuaan aktif ini adalah sebahagian daripada inisiatif aktiviti komuniti rakan aktif Parlimen Pengerang. Pusat penuaan aktif menggunakan peralatan senaman kekuatan otot isokinetik dan ianya adalah kaedah latihan otot yang paling selamat, berkesan dan paling menyerupai pergerakan otot manusia dalam penyelidikan klinikal di seluruh dunia. Peralatan ini dapat menetapkan kelajuan dan perubahan rintangan bersama dengan jumlah daya yang diaplikasikan oleh pengguna. Ini adalah peralatan senaman terbaik untuk warga tua. Selain itu, peralatan Dr. Fit Cardio dilengkapi dengan perisian Dr. Fit treadmill automatik pertama di dunia yang beroperasi mengikut kesihatan jantung anda. Ia membimbing anda melalui sesi pemanasan badan, dos dan intensiti serta sesi penyejukan badan secara sistematik tanpa rasa tidak selesa dengan formula heart rate return. Pusat penuaan aktif, kekal aktif untuk kehidupan yang berkualiti.
Which has started off the scientific program of this conference.
They expect the hospital to be a place where
become a urologist to manage breast cancer.
I'm actually lost of words because over the 3 days it was like, today it has been another historical day. Thank you.
The second World Conference on Exercise Medicine was held for 3 consecutive days, from 24th to 26th September 2018, situated at the World Heritage Site in Malaysia, Malacca. Coming to its second year, the World Conference on Exercise Medicine had received overwhelming participation. In addition to receiving support from the European Medical Association, Malaysia's Ministry of Health, the Government of Malacca and respective corporate companies, the conference gathered participation from 35 countries and more than 500 medical experts from various fields. Biologists, representatives from international medical bodies and more joined this conference.
I'm glad that this conference managed to gather 30 over delegates all over the world, and together we make the conference successful.
We are contributing our part and have aligned ourselves to the WHO global strategy, which is to reduce physical inactivity by 10% worldwide. So we believe that this complete program, which is being carried out, will bring efforts to reduce or to contain the mortality rate caused by NCD.
We are able to assemble here with a bunch of scientists, medical specialists and so forth. And we have a lot of medical doctors this year round. And I have 35 brains from 35 nations, 65 speakers in total. So basically, this is something that we hope that we can impart to all attendants here, that you can go home with some knowledge about exercise.
More to mention, Dr. Sri Jessie Lai had also announced a collaboration effort with the Ministry of Health by setting up its first exercise medicine clinic to promote and introduce exercise medicine in our country. Through this conference, medical experts from various fields and experiences shared their respective exercise medicine-related research reports and further discussed with the experts who were present. This 3-day conference captured more than 60 topics related to exercise medicine.
Not so many people know about aviation medicine, but it is very important in military side. They are working in a very abnormal environment.
Pick up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. Here is where we stand. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Let your steps pick the way for the future, 'cause you're alive, inspiring others. Don't you lose your hopes due to hurt and loneliness, 'cause there's always another way. And all the nation together as one, fighting for a brighter future, gathering all our brothers in arms. Here we will stand tall. Pick up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. Here is where we stand. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Oh, let your steps pick the way for the future. 'Cause you're alive, inspiring others. Don't you lose your hopes due to hurt and loneliness. 'Cause there's always another way. And all the nation together as one, fighting for a brighter future. Gathering all our brothers in arms, here we will stand tall. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Just keep moving. Just keep moving. Just keep moving. So just keep moving and don't stop.
Okay, good afternoon to all the delegates and good morning to delegates from other part of the world. Once again, we are here on the fourth day. Wow, time flies fast, isn't it? I still remember that when we first launched the conference, and today we are arriving to the fourth day. Anyway, today we have quite a lineup for everybody here. I noticed that there are more than 100 people in attendance now, and the number will grow. Paper number one will be by Associate Professor Dr. Hashpullah from Malaysia. Then we have the second speaker. The first speaker will talk on sudden death. Second speaker, a good colleague of mine, Professor Dr. Berkesh Ishwan from Hungary. Then we have the third speaker, Sufan. She was the president of the Malaysian Physiotherapy Association. She will talk on Keynote paper Keynote to basic musculoskeletal injuries. And then we have Professor Dr. Zombo, right, from the Hungarian University of Physical Education. He will be touching on the paper on regeneration orthopedics. This is an interesting paper. Then lastly, we have another paper from Japan, and this paper will touch on types of resistant equipments. I think this is very important, all right? We have been always talking about how physiological changes, the systemic changes, and the neuromusculoskeletal changes when you exercise. But we must remember the apparatus, the equipments that we use, the equipments and apparatus who has been those equipments that has been manufactured with science and good biomechanics. It reduces less injuries and also it gives you a more accurate feedback. Okay, so today we have 5 interesting papers. All right, without delay, I think Associate Professor Dr. Hashpullah, he is always ready. All right, he has a PhD in cardiac rehabilitation, specialized in the chronic heart failure. I think this will be a good paper for him to talk about sudden death, because we have seen a lot of sudden death of late. And he is also a clinical exercise physiologist in Shah Alam, at his rehab specialist center. And also he is also the head of the Center for Health, Wellness and Human Performance. It's Industrial Link Community Alumni Entrepreneurship in UiTM Malaysia. All right, this is one person that you must not miss. Listen to him and learn as much as you can. Okay, Dr. Hashpullah, I have the floor for you now. Please.
Hi, Assalamualaikum warahmatullahi wabarakatuh, and a very good afternoon to everybody. Firstly, I would like to express my gratitude to World Exercise Medicine Conference 2021 because inviting me to share some information on the sudden cardiac death in sports. So that will be my topic today, and I would like to share in terms of how to identify these patient or athletes and what kind of assessment that we can do in order to reduce the hospitalization and also definitely will decrease the incident of the death. So allow me to share my slide. So hopefully that from there we can have more understanding. So I will start my presentation by introducing myself. My name is Hasbullah Ismail, and currently I am a director of the Industry Network Center in University Technology Mahara Shah Alam, Malaysia, and also as a senior lecturer at the Faculty of Sports Science. And meanwhile, I'm also the president of the Malaysian Exercise Sports Science Associations, MESA. And today topic will be a sudden cardiac death in sports. Identification and assessment of the risk factor. We know, guys, that in the situation of athlete while they are doing the physical activity, and we know that they are considered normally when we talk about exercise, and those who are regularly exercise, they are considered healthy, but there is several occasions where while they are doing the physical activity or doing sport, they can get the cardiac arrest and some of them died because of that. So hopefully that by the presentation today, we can identify the risk factors and do some assessment to reduce the hospitalization and also to reduce the incident of cardiac death. So appreciate the definition of the sudden cardiac death, or what we call the SCD. The American College of Cardiology has defined the SCD is a non-traumatic and unexpected sudden death that can occur from the cardiac arrest within 6 hours of the condition of that particular person considered normal of the health. So within 6 hours, there is no incident of this abnormality, and then suddenly they can get sudden death. That is considered as the SCD. And Halakchi 2011 the paper that mentioned by this team, that the SCD can be defined that as a death within 1 hour of the onset of the symptom without history before that, on cardiovascular abnormality, respiratory, cerebrovascular, and drug-related death, and more or less the same that like as American College of Cardiology definitions. But in sports-related of SCD was defined as a non-traumatic SCD during or within 1 hour of certain level activity of exercise, or what we call as the intensity. In this case is between moderate to high intensity, where when we mention moderate, the heart rate reserve is around 65%, around 65%, and almost to 100%. Heart rate reserve we consider as a high intensity. So let's talk about the pattern of this SCD. The incidence of the sudden cardiac death during exercise is around 1 per 200,000 to 250,000 on normal populations yearly. However, in athletes, it can go 1 over 50,000 to 1 to 100,000 annually. It shows that 2 or 4 times more compared to the normal populations. So it gives some ideas that those who are doing exercise or doing physical activity, if they have a probability or risk factor of SCD, they can easily get that, compared to those who maybe have a symptom but they do nothing. So it's going to be 1 over 200,000. So among the competitive athlete, it has been reported that around 20 to 35 sport-related sudden cardiac death has been reported annually in the studies done in United States. So, guys, if we look into this, most of the research paper and the study has categorized those who get SCD by the age. Those who are more than 35 years old and less than 35 years old. In terms of statistic, shows that above 35 years old, among 1,000 population, 1 can get SCD. On 35 years old and below, around 1.5 to 6.5 over 100,000 per year. So it seems that those get this sudden cardiac death, that below than 35 years old is considered less and rare. So let's look into athlete specifically. In young athlete, based the study by the Ferreira in 2010, the SCD often occurs from those who have hypertrophic cardiomyopathy, and this is the condition where the thicken of the heart muscle and specifically to the septum. So it will delay the electrical conduction. Electrical conduction will stop or will delay the process of contraction of the heart, because the heart need to contract accordingly to the intensity of the exercise or the level of the exercise. That is on young athlete. But on 35 years old and above, basically they all die due to the complication of the coronary heart disease. So it's been clear that coronary heart disease is the factor, and among this factor, the major cause is come from the atherosclerosis, and this is the what we call as fat accumulation and the cholesterol that accumulate at the blood vessel of that particular person, and they block the blood to enter to that area, and this will lead into the condition what we call as the myocardial ischemia, where we know that myocardial ischemia is unbalance between supply and demand in terms of oxygen. So the demand is very high because we are doing the exercise, we need more oxygen, but the supply is very less because of less of oxygens can go through to the body, to the cells, and this will lead to the condition what we call as the myocardial infarction. That is a heart attack. Basically, acute myocardial infarction will be happen, and this will lead into the sudden cardiac death. and this is contribute to 80% of the population of sudden cardiac death. So it's very clear, guys, that there is two ways to look: 35 years old and above, and below 35 years old. So if below the 35 years old, the population is very rare, and those who are above 35 years old, and that is due to coronary heart disease. I recap that. So we talk about 35 years old. Who is the person that basically can easily get sudden cardiac death? Basically, that is because of the congenital abnormalities of the heart. They get it from the birth. So most common factor is come from the hypertrophic cardiomyopathy, as I mentioned just now. And another one, it could be because of coronary artery anomalies. This is the abnormality of the heart, and that they can come with symptom or without symptom. If with symptom, basically they can get chest pain, and sometimes they get fainted during exercise or during physical activity. And another reason why they get the left ventricular hypertrophy, that is considered the increasing size of your heart. Ventricular is the bottom from the heart. So once they get increasing of the size, they will delay the electrical conduction from the SA node, AV node, and from the Purkinje fiber of the heart, delay to the particular area of your heart. So this will make your condition easily to get cardiac arrest. So another reason of disease that can happen that below 35 years old is the condition what we call as ARVD, arrhythmogenic right ventricular dysplasia. This is the condition where your right ventricle at your heart on the right side, that the muscle is replaced by the fat and also the fibrous tissue. In this will make your blood vessel at that area dilate, and this will weaken of your heart. So once your heart weak, so it can make ventricular arrhythmia happen, where your heart going to be irregular, and they can get that particular person can get cardiac arrest or easily to get that because of that. Another reason is the Marfan syndrome. This is the condition where the gene mutation and will affect the connective tissue of the body, including of the heart. And the long QT syndrome, this is the delay of the electrical conduction. Brugada syndrome, same thing, also the genetic problem. And the catecholaminergic polymorphic ventricular tachycardia, where this is the condition where the ventricular arrhythmia, irregular of the heartbeat, will make the ventricular tachycardia, make the heartbeat to go very fast, and this can lead into the cardiac arrest. So that is on 35 years old below, and this is the risk factor of the sudden cardiac death of above 35 years old. Since that we know that 80%, we can say that 88% of the sudden cardiac death happen during the physical activity to those who are 35 years old. So we need to consider of the risk factor of this one. So basically risk factor of the coronary artery disease. So look into the age factor. Those who are above 45 specifically, they are already considered moderate risk. The hypertension, the left ventricular hypertrophy, this is we make the thicken of your blood vessel and a thicken of the blood. So also the delay, the aging, delay the electrical conductions, intraventricular induction block, the condition where your electrical conduction being blocked into the first degree or second degree. You know that the heart will contract 2 times. Once is atrial, after that ventricular. So from atrial to ventricular, it will take time. More than 300 millimeter per second, that is considered blockage of the electrical conduction, and the contraction going to be delayed. So sometimes the atrial conduction on the top of the heart contract, and there is no contraction at the ventricular, at the bottom of your heart. So contract 2 times and then again ventricular. So this is considered at the second degree of the AV block. So as I mentioned just now, serum cholesterol, this is the main things that can happen on the atherosclerosis together with the fat that accumulate in the blood vessel, glucose intolerance, the insulin's insensitivity will make the condition getting worse, and the vital capacity, the heart, the lung capability of breathing reducing. So this will make the SCD will be happen. And of course, smoking, the relative weight, as we know that the fat distribution at a certain area of the body and the irregular heart rate can easily get the sudden cardiac death. So in cardiac rehab program, we know that those who have this 35 years old and above, they need to go for cardiac rehab program. But during the cardiac program, it appears that on one in over 12,000 to 15,000 during such setting, they get cardiac arrest, and the cardiac arrest also 6 times greater than the general incidence of the sudden cardiac death for patient known to have a heart disease. So this is a study by the Taylor. So guys, during physical activity, we know that vigorous activity can trigger or the sudden cardiac death. That is, we make the heart attack also, myocardial infarction, and that is because of the blood thickness, or what we call is the increasing platelet adhesiveness and aggregability. So moderate physical activity may be fine, good, but if you want to go more than moderate activity, vigorous, or in fact high intensity, of course, there's a debate yet. Some scientists says that it may be safe if we follow certain regulation or certain procedure, and it can give more effect, better effect. But that is still considered a debate. But the conclusion shows that doing the exercise is a way to reduce, to get the sudden cardiac death. So this is the high risk factor that we need to consider. The 4 variable identified patients who have risk of sudden cardiac death. First one, if they get syncope or fainted before first of the episode of arrhythmia, the irregular heartbeat. So this is considered high. They already have the history of that. Another one is the history of the myocardial infarction. They get heart attack before, and also the family history. They also can have high risk of that. And if we already the doctor already put you as a NYHA, the New York Heart Association class 3 or 4, where this condition you are during rest, you feel okay, but when you start doing the physical activity, you feel discomfort. That is the class 3. And class 4, of course, that you, in fact, during the resting, not doing anything, you feel discomfort to your heart. So that is considered high risk factor. So another things that I think from here we can do some precaution when we know that that particular person have a ventricular tachycardia, where the heart beat faster more than 100 during resting, or can go up to 200 beat per minute, where this is considered ventricular fibrillation. So that is occur after myocardial infarction, after heart attack, 3 days to 2 months. So this is the high risk factor, and I fully recommend during this time we need to make sure that that particular person to purely rest and make sure that everything is in control first. So the left ventricular dysfunction is one way how we can predict of the sudden cardiac mortality. This is we can use of echo by looking into the left ventricular ejection fraction. The blood that go and in and out from the heart is less than 30%. Normal is around 60% and above. So that is considered dangerous and high risk. And I would like go into scanning and testing. So the presence of the AV block at the ECG pattern can give some idea that they probably can get easily cardiac death. by looking at that. And also the QT prolongation, if the QT prolongation more than 460 millimeter per second, that is consider too delay. So in terms of the atrial and ventricular, and that could be very dangerous. And during that time, mostly of the heart, there will be a slow heartbeat, bradycardia, slow heartbeat. But if the resting heart rate suddenly increase more than 90 beat per minute over 100, that is the situation is going to be more dangerous, because they are approaching the ventricular tachycardia, the heartbeat more than 100, and that can lead into the ventricular arrhythmia, where the heartbeat irregular, and this can lead to the cardiac arrest and also to the cardiac death. So this is the example of one patient that have been done through the clinic. When he came and see me, and this is the age of 50 years old. He's considered active in exercise. However, he has a condition of ventricular not re-entry tachycardia, where this is one type of the supraventricular tachycardia. One type of the heartbeat go very fast, more than 100. So it happened in April. This April 29, 2021. So when we look into CT scan normal, so he came and did the ECG to see whether there is a presence of AV block, as I mentioned just now. So there is no sign of AV block. So this is an example of the ECG result, and we can see that the rhythm of the ECG look very normal from the lead number 2 here, from here and here, R to R looks very normal, and P wave to QRS also look very normal here, and there is no left ventricular hypertrophy, even though that is looked like ventricular hypertrophy, but not yet. So it's considered like borderline, and I consider this guy as a normal ECG pattern. And when I look into the amplitude of the ECG from P wave and also Q, R, and everything looks very normal here. There is within a normal range. And the QT prolongation, there is no QT prolongation here. So within range 350 over 350, within 350 to 460 milli per second. So it's considered normal. So even though that happened the episode of AVNRT before, but when do this, there is no symptom of that. So even though that we start do the testing, give a challenge to the heart into the third level, from the level from 6 Met level quite low up to the 10 Met. So we can see that the heart rate here from 10 Met, the heart rate from 81 start the exercise testing. First 3 minutes go into 80, and then next stage 82 over 103, and the BP also looks normal, increasing steadily, and the RPE, the rate perceived exertion, the fatigue level over 10, also very low, 2, 3, and then go into the third stage. From the third stage, at the 9 minute, the heart rate is 146, and is equivalent almost 75% of heart rate maximum. So here heart rate maximum 143, and this is 146, and the BP also looks considered normal, 160 over 80, is increasing steadily accordingly to the MET level, and the RPE is still 4. So when we look into recovery, the recovery also, the heart rate go back to normal after minute 5, and then the BP also reducing accordingly. So this patient considered normal, even though that they have he has been diagnosed as AVNRT. So during the stress level testing, I didn't see any ST changes, there is no ST elevation, there is no also ST depression. So it looks very safe. And from here, you can conclude that even though that we might be prone, and this guy is not even 35, is already 35 years old. So the most factor that we need to consider here is the coronary artery, heart coronary artery. So we need to consider that risk factor of that rather than the below 35 years old. As far that there is an effective and efficient measure addressed, then the sudden cardiac death should be very safe or should be controlled to the people. And regular exercise can decrease the cardiovascular morbidity and mortality. In fact, the vigorous exercise, particularly for untrained, perhaps can give some adverse effects, so they need to do some assessment first. So that's all on my presentation. So keep safe and have a nice day. Assalamualaikum warahmatullahi wabarakatuh. And thank you.
Thank you. Thank you, Professor Dr. Hashpula. You have given a very good insight. I think more people should be aware of what they should do due to the fact that now everyone is aware that exercise is very important, especially during this time of pandemic. All right, I think you have 4 questions, Doc. Let's 5 questions. All right, the first question is, what is your opinion for mass people joining running event that organize more than 1,000 kilometers? Is it good for cardiac?
Okay, thank you, Prof, and thank you for participants for listening. So very good afternoon, the time in Malaysia. So direct to the question, my opinion on the mass people that joining running more than 1,000 kilometers. So this is like what we call as the ultra marathon. So at first place, the question is it good for the cardiac? So one thing about the aerobic activity, the running, the swimming, the cycling, the exercise that we do for the heart is all we call as the aerobic. And basically to make sure that we get the optimum basically on the heart, it only need between 30 to 45 minutes. And the maximum is going to be 1 hour. So those who are doing more than 1,000 kilometers, they are exposed to the condition perhaps like electrolyte imbalance, because they're going to reduce some of the sodium, for example, and then it makes some dehydration going to occur. And another thing that might be happen, the hormonal changes will be affected also. So through my opinion, those who are doing exercise or doing the marathon runner, especially that like marathon runner, they are exposed to some what we call as dangerous condition, and they need to have some precautions before doing that, because even though that during 20 to 30 minutes of running, when we drink a lot of water, we still dehydrate. So just imagine that if they are doing like 1,000 kilometers. So that is my question on that. Answers on it.
Right. Thank you, Doc. The second questions. What happened on the left ventricle from 2 types of exercise, aerobic and anaerobic?
Okay. Basically, when we say aerobic, that is exercise specific to the heart. When we say about anaerobic, is exercise that relate more on the muscle, more on the muscular endurance. Okay, let me talk about this aerobic. Anything that exercise we do on the aerobic types of like running, swimming, and they will give some increase in the mass of the ventricular. So it's something like a balloon. When we keep on pushing our heart, it's going to be dilate the heart like a balloon. Just have that kind of imagination, and then just imagine that the blood that go from the balloon is going to be very fast. So it seems like they're going to wash really wash all the atherosclerosis of the cholesterol, but it seems that very good. So exercise is very good for the left ventricular, meaning that that is the bottom of the heart. We have two sections. At the top atrial, at the bottom is a ventricular. So the left ventricular going to be a little bit thicker, and that is good. But for anaerobic, so especially for those who are reached 40 and above, people might be saying that what happened to the anaerobic? So while we are doing the cardiovascular, basically, it will give a little impact, but not so much like aerobic. But because of above of 45 years old, as example, so we still need to do anaerobic exercise because it gives some hormone assistance to do. So it's not going to be the same like below than 35 years old or 45 years old. So still both good, anaerobic and aerobic. We should have do both exercise basically.
Okay, thank you. We'll go on to the next question. We have, I think we got 3 or 4 more questions to go. All right, just in case, just in case we don't have enough time, we will get your email to the person who asked you the question. All right, can an athlete and mass people train more than 100% from their maximum heart rate, like lifting weight or tabata? What happened to our cardiac? Is it dangerous?
All right. This is something that quite interesting. We always think that when we push our heart up to the 100% maximum heart rate. So basically the calculation, the basic calculation based on the Covenant method, 220 minus age, that is the maximum of the heart rate. But without we realize sometimes when we pushing ourselves a little bit faster than usual, if we are doing running, we reach the 100%. But the problem whether we can stay that more than 10 seconds or not. So when you ask me whether that it's safe, yeah, it's going to be safe if we have some screening, a proper screening, especially for those who are 40 years old. They need to do a screening, as I mentioned just now in the video, that those who have a sudden cardiac death happen, mostly happen to the above 45 years old, 80%, and that is because of the atherosclerosis or something that related to coronary artery disease. So that is related to the lifestyle. So that is the question on maximum heart rate.
You have one question from Pakistan, Dr. Salim.
Yeah.
Are there any studies which compare epidemiology across different sports?
Well, to be specific on sports, I seldom see that research paper. Like example, for the football, for the rugby, example for the badminton. But basically, most of the epidemiology studies or research is based on the type of activity, like aerobic, that related to the heart, or anaerobic or resistance training. So specific to sports, we ourselves as a researcher need to convert those who have example like football. So football is a combination of the aerobic and the anaerobic. So we need to look into both. Specific to sports, not so many, even though that maybe we have that also. So I suggest that to be more accurate in terms of the finding on the research, we need to look in terms of the energy system, so aerobic or anaerobic.
Okay, thank you. We have 2 minutes more to answer. All right, get a short one. What is your advice on keeping GTN on standby?
Yeah, well, not only for those who are doing exercise, they need to do screening at the first place. So the screening not only on the GTN, they should also, example like for the diabetic, so they can do exercise, they can go up to the certain intensity of like 85% of maximum to the maximum of the heart, but they should have this these precautions. So those who want to do the exercise, especially that those who have a heart problem, I fully recommend. There is no reason that they cannot do the exercise, but the only difference that if they cannot do outside alone, they need to do it clinically or by supervision of the heart practitioner together with them. So my advice, yes, they should have standby for that.
Okay, thank you. Next one is that I'm trained. One client have to go through bypass operation more than 5 years. Or I think what he meant was that he had a client who did his bypass 5 years ago. Can I push him sometimes in exercise more than 80 to 100% of his maximum heart rate? The reason I want is to challenge his cardiac with higher intensity training.
Okay. This is a very good question, especially for the health practitioner. That if we want to prescribe exercise program or rehab to those who have the myocardial infarctions. So basically, if 5 years, yeah, they can push up to 80 to 100%. The only high risk that basically we need to look is within 2 to 3 months of episodes of myocardial infarction or any operation, major operation. For 5 years, they not even they can encourage to do 80 to 100% under the supervision of clinical science physiologists or physiotherapists or even medical doctors. But still, we still need to look into the possibility of the high risk, as I mentioned just now, whether they have the episode of the syncope, fainted or not. I can hear you. I think.
Sorry. Yeah, this is one thing that always happen to me. I forgot to unmute. All right, I think time's up for you on to answer the rest of the questions. Appreciate if you can type an answer here, or we will send your email to the people who asked the question. Is that all right?
Yeah.
Okay. So thank you very much. All right. Well, thank you. Okay, we'll proceed on to the next speaker. Speaker number 2, Professor Dr. Prakash Ishwan from Hungary, right? Can I have this? Just give me a minute. There's a little bit of technical hiccup here. Dr. Prakash, 1 minute, please. Bocano. Okay, here we go. Dr. Prakash, he will be talking on prevention of sports injuries during the COVID-19 epidemic, and as a professor emeritus at the University of Physical Education and Semmelweis University in Budapest. He's a clinician. He practices in Cadiz Lepak Private Clinic, Tata, and St. Doha Private Hospital, Budapest. As I know, Dr. Prakash is a very well-known orthopedic surgeon, and he has a few hospitals under his management and care. So it's a great pleasure, Dr. Prakash. I have not seen you for some time. Coming to Hungary at the end of this year. Okay, so Dr. Prakash, please proceed on to your paper. Thank you.
Thank you, Professor Lil. Many greetings from Budapest, Hungary. It's a great pleasure for me to be here and to present our evidences and our experiences concerning this topic. I think it's very important to speak a lot about the prevention of different sports injuries during the COVID epidemic. And I would like to emphasize that the first part of my lecture, I will speak about in generally the prevention concerning the sports injuries during the COVID epidemic. And second part of our lecture will be present by my colleague, Dr. Rehan from Pakistan. He is working actually together with me in Budapest. So we prepared this lecture together. That's why we are present both our experiences. As you know, this is our university, the physical education. It was the home university of Professor Lee as well. And Professor Dr. Rehan, who is a physiotherapist, works actually the Symposium University in Budapest. So we have the experiences of both universities. So what is the main problem? As you know, both athletes and coaches are at high risk of getting infected with COVID infection by playing different sports. And as we know, this is especially possible in environments where athletes train in group and do contact sports or use common areas like changing rooms. And in these circumstances, the transmission can occur by direct contact with an infected individual through an object contaminated by indirect exposure to the virus, or by aerosols or drops from the infected person. And this could be a real danger. And we know also that given the beneficial effects of regular physical activity on physical and mental health, it's very important to remain active during the COVID-19 epidemic, of course, following the epidemiological regulations like social distancing, hygienic measures. Due to the mandatory closures and restrictions, as well as the rules of social distancing, the possibilities of associations, gym, and other social sports were reduced. Instead, these sports activities at home and out of the ordinary training centers like home treadmill trainings or long distance running in the evening came to the force that was often done incorrectly by people, which could have led to various injuries. It's a very, very big danger in our time. To know the correct data, we performed a survey in our universities, and taking advantage of the popularity and massive use of social networks, we conducted a survey through Facebook between September 14, 2021 and September 20, 2021. What was the aim of our survey? The aim of our study was to find out the main types of musculoskeletal injuries that occurred during exercise by pandemic, and then to make recommendations for their prevention based on this. Look at these slides, you can see the methodology of our survey. This questionnaire includes the questions that were compiled using research from Martinez, who lives and works in Spain. Our 11 multiple choice closed-ended questionnaires uploaded to Facebook were completed and returned by 112 individuals, among 61 men and 51 women. Of the respondents, 68 were under 48 years of age. It means that these kind of patients were relatively young. Prior to closure, 94 of the 112 respondents play sports more than 2 times a week. Look at the results. Among the participants, 41 people, it means that 37% moved more than before. It's a good one. Good news. 52 people, it means that 59% moved alone, and 42 people, it means that 25% performed physical activity online using YouTube tutorials. What kind of exercises was performed by our clients? Respondents mostly performed aerobic exercise and muscle strengthening. What was the most popular type of the program? The most popular type of the program consisted mainly of long-term running and high-intensity and short-term exercises. Of the latter, like CrossFit, HIIT, and Tabata, weight training, and finally yoga and pilots, and walking were ranked in terms of frequency. Of the 112 respondents, 46, it means that 41% suffered musculoskeletal injuries during closure. There were those who did more. Of the injuries, muscle injuries occurred in 20 cases. It means that 18%. Knee injuries in 16 cases. It means that 14%. And other joint injuries in 17 cases. It means then 15% as well. Of the injured, 39 people required medical care, during which 22 cases, it means that 29% were conservative treatment, like rest, intermittent local cooling, different non-steroid anti-inflammatory drugs taking, and 7 cases, it means 4% underwent some kind of surgical procedure. What should be the conclusion? Frequent and long-term runs have been associated with predominant lower limb overload injuries, such as runner's knee, the so-called jumper's knee, pes anserinus syndrome, Hoffa disease, they are very interesting, and Achilles tendinopathy, it were very frequent, as well as hamstring and gastrocnemius muscle strain. Most of the injuries were due to the running on hard ground and repeated knee twists. The marathon run, it means that to run 42 kilometers is not so easy. Advertised on social networks and the long distance race on home treadmills and rowing benches also had a number of negative consequences. The vast majority of respondents carried out their sporting activities independently, and probably many of them can be not only ineffective, but also dangerous. It's a problem. The same risk was borne by other respondents who used YouTube and social networks to do exercises. Unfortunately, these programs don't take individual capabilities into account, and even worse is that many of the influential staff, these online networks, don't have the necessary professional qualifications. It's also a very big problem in this relationship. And now, coming to the discussion, we consider the strengths of our investigation to be a very timely problem and to draw the attention of the public and authorities to the dangers of physical activity at home, which is particularly important during the COVID-19 epidemic, and to the prevention of potential injuries. We are aware that our present online survey, of course, has serious limitations, and this type of small-scale online survey does not allow for obtaining credible statistics, nor is it impossible to pinpoint true injury of respondents. However, based on the obtained results, we consider it necessary to describe the symptoms and methods of the treatment for runners and jumpers knee, pes anserinus and Hoffa syndrome, Achilles tendinopathy, and hamstring and the gastrocnemius muscle strain among the overall sports injuries of the lower limb, including the opportunities for the prevention, which should be the main methods to prevent different sports injuries and different exercise injuries in this time. And now we will present this kind of special overload injuries by runner, Skinner, and the others. But the presentation will be continued by my colleague, Dr. Rehan.
Thank you very much, Professor Barkesh. So let me continue with the low limb overuse injuries. And I will actually explain the symptoms, the treatment options, the rehabilitation options, and the prevention of these common musculoskeletal injuries. So first of all, runner's knee. Runner's knee is dull pain around the front of the knee. It may be caused by structural defect or a certain way of walking or running in athletes. The symptoms include pain and rubbing, grinding, clicking sound of the kneecap. Treatment includes not running until the pain goes away. It means that mostly it's conservative treatment, also using cold packs, compression, and elevation. Medicines such as non-steroidal anti-inflammatory medicines can help reduce the inflammation and manage pain. Among physiotherapy, stretching and strengthening exercises can help prevent runner's knee. The next is the jumper's knee. Jumper's knee is actually the inflammation of patellar tendon. Jumper's knee is a sports-related injury caused by overuse of the knee joint. Common signs of jumper's knee include pain and tenderness around the patellar tendon, swelling, pain with jumping, running, or walking, pain when bending or straightening the leg, tenderness behind the lower part of the kneecap. It is diagnosed by taking a medical history and doing a physical examination. Sometimes x-rays are also required. The best treatment for jumper's knee is to stop any activity that's causing the problem until the injury is healed. So we actually provide body to heal it by itself. Other treatments may include non-steroidal anti-inflammatory medicines, rest, elevation, ice packs to the knee to improve the swelling and to manage the inflammation, and the stretching and strengthening exercises among the physiotherapy and rehabilitation program. The next most common thing is pes insurance syndrome. Pes insurance syndrome is actually a bursitis. Bursa is a fluid-filled sac inside the knee joint. When it becomes irritated and produces too much fluid, this is called the pes insurance bursitis. The bursa swells, causing knee pain and tenderness, and this condition is called pes insurance pain syndrome, PAPS. The most common cause of PAPS are injury or overuse, but it can also be caused by infection. Pain, swelling, and tenderness in the knee joint are most common signs of PAPS. It can be treated with rest and medicines to help with inflammation. Antibiotics are actually used if infection is found. If needed, surgery can also be done to remove the bursa. We can prevent bursitis by doing things like warming up before exercise or sports, increasing activity slowly, padding the joints, taking rest breaks often, and stopping activities that cause pain. The next is the Hoffa's syndrome. This is inflammation or pinching of one of the fat pads in the knee joint. The Hoffa fat pad sits behind and just below the kneecap. Its function is to provide a protective cushion between patella and tibia. It can occur either due to trauma to the area or due to overuse over time. Tight quadricep muscles, prior osteoarthritis, damage to the fat pad, or an anterior pelvic tilt are the major risk factors. Symptoms include pain at the front of the knee or patella, swelling below and around the front of the knee, pain in full knee extension during walking, squatting, and kicking for long periods, pain when wearing certain shoes such as high heels in female athletes. Hoffa syndrome, how to prevent and what kind of therapy we should give. Reducing the inflammation around the fat pad, this can also be done through treatments such as acupuncture, EMS therapy, ultrasonic therapy, cryotherapy. One can aid this process at home by using ice around the painful region, but remember that always get advice from the professional rehabilitation expert. Stretching the quadriceps and hip flexor muscles. This can also be helped through massage and vibration therapy. Strengthening the hamstrings, gluteus muscle, and muscles around the knee. Biomechanical work with an injury specialist to ensure the kneecap moves correctly. This will decrease irritation of the fat pad. The next is Achilles tendinopathy. Achilles tendinopathy is a painful syndrome affecting Achilles tendon. It can be mild, moderate, or severe. It can have various causes, but in most cases, Achilles tendinopathy is an overuse injury. Symptoms include pain in the back of the heel, difficulty walking, swelling, tenderness and warmth of Achilles tendon. Diagnostics include medical history, including exercise habits and foot wear, physical examination, especially examining for the thickness and tenderness of the Achilles tendon, and tests may include an X-ray, ultrasound, blood test, and MRI scan of the tendon. Treatment includes rest, NSAIDs, physical therapy, and avoiding activities that aggravate the condition. How to prevent Achilles tendinopathy? Achilles tendinopathy can be prevented by incorporating stretching into warm-up and cool-down routines, maintain an adequate level of fitness for sports and avoid dramatic increases in sports training. In case of pain in the Achilles tendon, rest the area. Trying to work through the pain will only make injury worse. Wear good quality supportive shoes appropriate to the sport. If there is foot deformity or flattening, obtain orthosis. Avoid wearing high heels on a regular basis. Maintain your foot in tip-toe position, shorten your calf muscles and reduces the flexibility of Achilles tendon. So it's very important to maintain the flexibility of Achilles tendon. An inflexible Achilles tendon is more susceptible to injury. And of course, maintain a normal healthy weight is very, very important in this case. Next, I will discuss a couple of muscle strains. First of all, hamstring muscle strain. A hamstring muscle strain, sometimes called pulled hamstring, happens when one or more of the hamstring group muscles get stretched too far or start to tear. Hamstring strains can be mild with little pain and a short recovery time, or they can be severe and need surgery and crutches for weeks. Symptoms include cramping, pain, swelling, bruising, tenderness, redness, and difficulty in walking, jogging, and running. Regular stretching, yoga, and other flexibility-based activities can prevent the disease. Treatment options include RICE. It means rest, icing, compression and elevation program, physiotherapy, tone facilitating massage, use of physical agents and electrotherapy, NSAIDs, and muscle relaxants. Here we can see that we are applying an ultrasonics to a patient with the hamstring muscle strain. Next is the gastrocnemius muscle strain. This is also very common in athletes. Gastrocnemius is considered at high risk of strains because it crosses two joints, the knee and the ankle, and has a high density of type 2 fast twitch muscle fibers. A tear of the medial head of gastrocnemius muscle is due to an eccentric force being applied to the muscle when the knee is extended and the ankle is dorsiflexed. The gastrocnemius muscle attempts to contract in the already lengthened state, leading to tear of the muscle. Symptoms of gastrocnemius strain can include subjective reports of sudden sharp pain or tearing sensation at the musculotendinous junction. On objective assessment, there will be tenderness to touch at the point of injury, swelling, bruising may appear within hours or days, stretching of the muscle will reproduce pain, and pain on resisted plantar flexion. Regular stretching, yoga, and flexibility-based activities can prevent the muscle to get strained easily. The principal treatment of calf strain consists of rest and allowing adequate healing time, but in severe cases, surgery is also necessary. Conservative treatment includes gentle passive stretching, isometric, then moving into concentric exercises. In the later stages, massage and electrotherapy can also be used. Thank you very much. And here we go to Professor Rakesh again.
Yes, and I would like to present our home take message that we are living in a very dangerous time. However, the exercise is very important. But we have to know that the exercise, even at home, could be very dangerous, but fortunately, they can be presented. But the knowledge of the prevention of different overload injuries and trauma injuries, it's very important. That was the main sense of our lecture today. Thank you very much.
Thank you, Dr. Bakash and Dr. Rehan. It's a pleasant day to meet you all again here. And thank you for the advice to your paper, because not only one country is affected by this pandemic, the whole world has been affected. And as we know, the situation of people who has been exercising have taken exercise to their home. And so your paper comes in at a very good time to advise all the people around the world. All right. I think you have, let me see, your questions. Yes, okay. You have two questions. The first question is, what are the differences between jumper and runner's knee?
Okay. The jumper's knee is occur in the frontal area of the knee, and the runner's knee is occur on the lateral part of the knee. The runner's knee exactly is a so-called friction. Runner's knee is a so-called friction syndrome because the friction of the tensor fasciae latae on the lateral side of the lower leg. And the jumper's knee, it's a so-called overuse injury, which affected the patellar tendon at the point of the top of the patella. It could be maybe a so-called impingement syndrome as well. No? So they are very good differentiated overload injuries. So jumper's knee and runner's knee.
We have another question. Yes. Okay. From Malaysia, Bahagia. How about varus and valgus problem, the knock knees? Can exercise fix this problem?
Maybe not to fix, however, help to the overloading of one part of the knee. You know, different varus alignments could be very dangerous for the later condition of the knee, especially among the athletes in a competitive or leisure athletes. But we should control the different varus different malalignments, and maybe we should protect them using different equipments like shoe sole or any others, you know, or using braces and special muscle training, strengthening of the lateral side and strengthening or stretching of the lateral side and strengthening the medial side could be also very successful. But the main thing is to gain a very correct diagnosis using objective methods like different imaging methods.
Thank you. You have two more questions, Doc. The next one is that now the recent trend of rise has become price and now is replaced by police. What's your opinion on that?
So actually, rise is the rest and icing and compression and elevation. But sometimes, and now it's also price or pricer. They say that the protection is also very important. Then yes, protection is of course very important. Then it becomes the protection and rest and compression and elevation and icing. So we actually provide the patient what actually is the most beneficial for the patient. In such kind of injuries, we have to provide the healing environment to the muscle or the tendon or to the injured part. So it depends upon the severity and kind of the injury, but I think that the other terms are also okay. But the rise was the simple term, which was these components are the most important, but of course the other components are also very important in this case.
Thank you. The last question is that for SI joint injury, how can I speed up the recovery? I had it after giving birth.
So the sacroiliac joint, so it depends upon that what kind of injury it is. I will mainly talk about the rehabilitation aspect. In SI joint, when we do the examination, we will of course see the inflammation, the swelling, what kind of mobility is there in the SI joint. We try to mobilize it in grade 1 and 2 of the Kelton-Bond technique, and then we see that how much is the immobility or decreased mobility, and what are the consequences, and where is the pain going, for example, and what are the activity limitations due to this. Then mainly we do the symptomatic treatment depending upon the examination and assessment, and if there is anything required to reduce the inflammation, to reduce the swelling, but then we do it in conservative as well as in the medical management. And if the if it's in the adult athlete, then we can also go for the surgical aspect as well. But it really depends upon the type of the problem in the SI joint and how much it affects the related and peripheral soft tissues and bony tissues.
Great, thank you, Dr. Rehan. Okay, I think that has been very knowledgeable, and thank you for your papers, Professor Bakesh and Dr. Rehan. So just give me a minute. My technical man has been giving me a lot of hand signal which I don't understand.
Thank you very much, Professor Lee, for the opportunity to be present our lecture.
You're welcome.
And I wish you a very successful meeting in the future as well. And you are welcome in Hungary anytime, as you know.
Yes, I have planned to come end of this year.
You're strongly welcome.
Yeah, okay, all right. Okay, thank you very much. We will proceed on to the next speaker. The next speaker, can I have the CV? There you go. Ms. Yu. Ms. Yu Sufan. She will be talking on exercise and rehabilitation, back to basic in the musculoskeletal injuries. She is a physiotherapist and was the president of the Malaysian Physiotherapy Association for 2 terms, and also the president of the Asian Confederation of Physical Therapy and vice president of the Confederation of Allied Health Professionals, and she has been certified in many areas of the body. And today she is going to share to us on this paper. Is this live? Okay, a recorded version, and Ms. Yu will be ready for your questions. All right, thank you.
Good afternoon, everybody, friends and colleagues, ladies and gentlemen. First of all, I would like to congratulate the organizing committee of 5th WCEM virtual conference. Thank you for giving me a slot to talk on my topic, that is back to basics in musculoskeletal injury. Lockdown was implemented throughout the world to cope COVID-19 from spreading. And during lockdown, many activities were restricted, and that have made us into couch potatoes. Inactivity or stationary lifestyle leads to deconditioning of our body. And what is deconditioning? Deconditioning is adapting to a less demanding environment, especially decreased physical activity. The conditioned body is more prone to common injuries of the musculoskeletal system during activities and sports. MSD, or musculoskeletal disorders or injuries, is the single largest category of injuries that is seen daily by our GPs or orthopedic department. And it is a huge economic and human cost as it runs into millions. Injuries or disorders that affect the human mobility or movement of the musculoskeletal system can be injuries or disorders. And muscles can get torn, ligaments will get sprained, tendons strained, capsular tear, bone fractures, cartilage chipped, disc ruptured or prolapsed. And disorders will be such as sarcopenia, which is the progressive and generalized loss of muscles, especially in our elderly who have no time or who cannot go out and exercise. Okay, then we spend more time with our laptop and mouse, and so we are more prone to carpal tunnel syndrome. Then we get tendinitis or tendinosis, trigger finger, neck sprain, arthritis, prolapse intervertebral disc. These are all the common musculoskeletal disorders. So you see ligament, we will have a sprain of the ligament. Tendons usually is strain. Muscles more commonly is tear, and bone is a fracture, okay, or wear and tear such as erosion of the joints or wear and tear of the joints such as arthritis. Now, why does injury happen? It happens when the muscles are actually not ready for exercise, activities, or work. For example, the muscle is still cold and at rest, and then suddenly it is forced into movement which is not ready, and therefore injury happens. Number two is weak muscles. When muscle fibers cannot cope with the stress that is put on it. For example, too much demands is placed on the muscles by exercise overload, sudden overstretch, extensive mechanical stress, or when we are working in awkward postures. Number three is prolonged overuse of muscles, tendons, or ligament. Cumulative forces which exceeds the tissue's ability to withstand such forces will cause injury of muscles, tendons, or ligament. It is either or can either due to one isolated macro-traumatic event, or it can be repetitive micro-traumatic events. And repetitive micro-traumatic events are called also overuse injuries or repetitive stress syndrome. Number four is work ergonomics risk factors. Poor work practices and awkward postures will place excessive force on joints and muscles. If you look at this dental technician working on the teeth, you look at his posture, his neck is almost 90 degrees compared to the thorax. So this will increase the stress on the neck muscles and the muscles of the upper back, on the ligaments and the tendons. And these muscles in this prolonged posture will cause muscle fatigue. And when muscle fatigue, they are more prone for injury. And also the joints are put way into excessive stress, okay? And this will cause wear and tear of the facets joint. And also his posture, in such a slouched posture, is placed a great load on the diaphragm, and the diaphragm is not moving properly. Therefore, this person is actually not breathing maximally. So when there is reduced oxygen, he is more tired, and when you are more tired, you are more prone to injury. So if we work prolonged at the computer, or when we work from home, or lockdown, we are not going out, but we watch movies on the TV and all this. When we adopt this posture, the neck and the back muscles are strained, okay? And the diaphragm are compressed. Now, hunched rounded shoulder, compressed diaphragm will give rise to very shallow breathing. Shallow breathing means there will be insufficient intake of oxygen. Lack of oxygen increases stress, and it builds up in the muscles, especially the muscles of the neck and the back. These muscles will become very tense, and they are the main cause of back pain and neck pain. Also, when we are not having enough oxygen, we tend to have more headache and brain fog. And when you have brain fog, you are more prone to injury as well. And every one of us are very familiar with text neck syndrome. Now, COVID-19 has quarantined us at home. So we spend more time now with our handphone and with our laptop. We know that when our head is in a normal neutral position, it only weighs about 12 pounds. But when the neck is flexed to about 60 degrees, the head now weighs 60 pounds. So the neck muscles actually have to work very, very hard because of the increase in the load of the head. So the muscles are put to stress. And if it is for prolonged hours, definitely the muscles under great stress will give rise to neck pain. So in summary, musculoskeletal injuries can be due to outside influence or internal influence. Outside influence, we can group it under ergonomic risk factors. That means working with excessive force, many times of repetition, prolonged overuse, poor postures, and over a period of time or exposure to risk factors, the musculoskeletal system are more prone to injuries. And the individual risk factors will be poor work practices and culture, and poor fitness. Physically, the person is unfit because of weak muscles, poor health, and poor health habits. And this, when the patient is working in this kind of physical build-up over time, the person is also more prone to musculoskeletal injuries and disorders. So how do we prevent injuries from happening? What is important is there should be proper conditioning and training. Our body is very resilient, but still needs proper care and optimal health to prevent injuries. Exercise and conditioning will prevent injuries, and therefore warm-up is important when we want to start our activity or exercise to prevent injuries. Cold, unstretched muscles are more prone to injury during workout than warm, well-stretched ones. So what are warm-ups? Warm-ups are activities made in preparation for the body for exercise, work, or recreation. They can be in the form of cardiovascular exercises designed to increase circulation, increase body temperature, and bring the heart rate up in preparation for an activity. The second warm-up can be stretching. Stretching is crucial for preventing soreness, and stretching to warm up and lengthen up muscles is important to prepare the body for optimal performance. The third one is calisthenic work, and these are exercises to help prepare individual muscle group for work and sudden movements. These are challenges posed to the muscle groups. For example, gentle squats, push-ups, lunges, and similar movements are important for preparation of a certain type of activities. The exact type of warm-up chosen for working out the muscle depends on the type of exercise or the activities to be performed. The other warm-up will include familiarization. For example, a shot putter, she or he will familiarize the movement before time for competition. Mental preparation is also a form of warm-up, and breathing exercise to increase oxygen to the working muscles is also a form of warm-up. Now, stretching of warm-up is commonly used for generations. Traditionally, and even up till today, stretching is considered as an ideal form of warm-up. Stretching is not as simple as we thought. We only thought that there is one form of stretching, but actually there are many types of stretching, such as passive stretching, static progressive stretching, ballistic stretching, dynamic stretching, and PNF. Now, depending on the activity that a person is about to perform, then different types of stretching can be prescribed. Now, why is warm down or cool down just as important as warm up? Warm downs offer similar benefits to warm up. That means it allows for gradual recovery to pre-exercise rate and also blood pressure. Cool down allows the removal of lactic acid and prevent accumulation of waste products, and hence delay or reduce the onset of muscle soreness. What is the basic treatment that we usually perform during an injury? First, early diagnosis and referral to appropriate discipline is important for rehabilitation. RICE and NSIT has been the cornerstone for simple injuries. And RICE means rest, ice, compression, and elevation, and NSIT is used to reduce pain and inflammatory response. To ice or not to ice? Should we rethink ice? This is the hot topic recently because there has been many discussions about icing during injury. Now, since 1978, ice has been used, and ice means only ice compression and elevation. And later R has been added, and R stands for rest, that is rest, ice, compression, and elevation. And 1998, P has been added to rise, and the P stands for protect. That means you protect first, you rest, then ice, compression, and elevation. And 2012, police was introduced. Police stands for protect, optimal loading, ice, compression, and elevation. Now, optimal loading has been discussed, and we will see why it is important. And 2014, rise has been retracted. So now in 2019, we have peace and love. Peace is for protect, elevate, avoid NSIDs, compression, education. Love is load, optimism, vascularization, and exercise. Why ice or not to ice? This is, as I mentioned, hot topic recently. Now, icing during acute injury during rehabilitation has been used for a long time, and we have been using it till now. But recently, there is a lot of confusion. Some claim that ice is good, but others say that it's not good. So ice is an integral part of acute injury management, but does this align with the latest research? Reasons for this change of thought or practice. Some claim that rest or lack of movement is detrimental to recovery. That's why we encourage patients to start movement and not rest. Now, it is claimed that optimal loading will aid the recovery through cell regeneration induced by light mechanical loading in early stages. That means we start getting the patient to start light mechanical loading. And ice is a great analgesic effect on acute injuries by numbing of the skin and by cooling the skin temperature. But is there an impact on the underlying muscles? The research shows that there is no impact on the underlying muscles. That means it's only at the skin level, and the cooling temperature actually makes the patient feels comfortable. Ice is claimed to reduce inflammation. The argument is that we need inflammatory cells to release hormone insulin-like growth factor, that's IGF-1. So inflammation is actually good for healing. The removal of inflammation will therefore delay the initiation of healing process. But too much inflammation is also not good. So we need to find the balance. Maybe if there is too much inflammation, then some form of ice can be used to reduce the inflammation. Now, ice also has been found to slow the blood flow and thereby slow the healing process. But if you still want to ice, then some has found that we can still ice, but not more than 20 minutes and no direct ice cubes, okay? Because it can be too cold, and also we should not ice it for too long. The argument is that we do not want reactive vasodilatation. That means initially there will be vasoconstriction, and then it will be followed by a rush of vasodilatation. Cooling will help to reduce pain and give the patients comfort. That's why icing has been claimed for this effect. How long do we ice? And according to Physio Network Australia, they use this C band. Okay, C means if it is too cold, burning sensation, aching sensation, or complaint of numbness, then we should stop and remove the ice. Next, the patient will ask that, why is my injury not recovering? Okay, so we have to ask this question. Are you getting the right treatment? Are you doing too much or too little, or doing exercise incorrectly? Or is there any progression to the exercises prescribed? It is important that we ask this question. Patient will need proper exercise prescription. Exercise is not done based on what I think is right. Okay, so what is exercise prescription? It's a specific plan of fitness-related activities that are designed for specific purpose, which is often developed by a fitness instructor or rehabilitation specialist for the client or the patient. Proper assessment and special tests should be carried out properly before prescribing the correct exercise for the patient. Prescribing exercise is never a cookbook approach, and is strongly discouraged because every individual's injury is special and different. Correct prescription will require the right type of exercise, the correct dosage, done at the correct time. That means at what stage is the injury, and for correct stage for that specific injury. The therapist must understand and apply training principles effectively in the presence of pathology, injury, and management done on the otherwise unhealthy tissue. So the prescribed exercise must be SMART. That means it should be specific, measurable, attainable, relevant, and time-bound. Let us look at what is specific. Specific means exactly what are the exercise that is prescribed, which is the target muscles, and we follow FITT, that is the frequency, the intensity, the type, and the time. Measurable means it's countable or it is time set. Attainable means which the patient will be able to carry out and achieve. Relevant means suitable, which can be done anywhere. For example, if you were to prescribe a treadmill, it may not be relevant for a patient who has no treadmill at home. Timely means we have to set achievable goal frame, okay? And the patient needs to comply with this goal frame that has been set. SMART goals are important in attaining the objectives of reaching optimal recovery. Therefore, to obtain a win-win situation, the patient has to agree on the goals that are being set. Being accountable to what is set is the only way to maintain long-term consistency and compliance. Principles of exercise prescription, we follow the FITT or FITT-VP principle, okay? F stands for frequency, that means how often each exercise is to be done. Intensity means how hard you have to train. Time is how long or the duration of the exercise. Mode or type is what kind of exercise. For example, running, walking, squats, mini squats, or whatever. And total volume is the total amount of exercise done. And progression means the advancement. Progress from step 1 to step 2 to step 3. And this is all based on scientific evidence. Progression of treatment depends on the individual's health and status of injury. Okay? We have to look at the physical fitness, the training responses, and the exercise program goals. And from there, we progress the treatment. Progression is done by increasing any of the components of FITT principle. That means we can either increase the frequency, the intensity, or we change the type of exercise, or the time, we can increase the time of the exercise. Recovery, compliance, and education is very important in the management of musculoskeletal injuries. Recovery not only depends on the correct supervision of the prescribed exercise, but also it depends on the compliance of the patient. That's why win-win goal has to be set. Education and empowerment of patients should go hand in hand when prescribing the right treatment so that the patient will achieve optimal recovery. Now, the take-home message is that during lockdown, SOPs all have to be followed. And for almost 2 years, we have gone through a series of lockdown, and this has created, like I say, many couch potatoes. I think many of us are guilty as guilty as this man. Incidents of NCD also will skyrocket during this time, and together with muscular deconditioning, this will further contribute to musculoskeletal injuries. Long COVID patients will have more deconditioning, not only to the musculoskeletal system, but to other systems as well. And to all this, the answer is exercise is medicine. Thank you.
Thank you, Sufan. Thank you for your paper.
Welcome.
I think you have 5 questions here, 6 if I'm not wrong. All right, the first one. Are you ready?
Yeah.
The first one is good afternoon, and how exercise can help coccydynia patients.
Okay. How shall I explain? we know that coccydynia is ecdycoccyx, and it is one place which is actually very difficult to exercise because it is a hidden place, and the muscles that is attached there is actually very difficult to access. So I would think that if a patient has coccydynia, other methods of physiotherapy actually will be more beneficial, but some form of stretching, soft tissue, manual therapy will be very important, because the areas around there will get spasm, muscles around that area will be in tension. So it would be good to do some stretching exercise and some manual therapy and soft tissue massage. That will be very effective for coccydynia.
Thank you. Move on to the next question. How significant are the changes in muscular length due to stretching?
Okay. All of us know that if muscles is not stretched pre-activity, muscles is in a shortened position. And if muscles are in a shortened position, they are more prone to injuries because they are not warm up yet. And we also know that lengthened muscles actually are more flexible. And when we stretch the muscles, there will be more blood circulation or improved blood circulation, and so also improve in all the proprioceptions. That's why when the muscle is lengthened, it is definitely in a more appropriate condition for us to start any form of exercise. So the changes will be, there will be increased flow of blood, and the muscle fibers are in a lengthened position, and also the stretch will help to create a better perception.
Okay, thank you. Your next questions that we have received is, as mentioned in the presentation, what will be the mechanism of preventing soreness by stretching?
Okay, the stretching I have already explained about causing increase in circulation, and also because of the lengthening of the muscle fiber. And when we stretch, we also increase our range of movement, and also we increase the flexibility of the muscles. And the other thing is that when the muscles is in a lengthened position, it is actually more right before performing an exercise. Now, soreness will come about because of muscle spasm, and then there will be soreness. And also because after exercise, or there will not enough warm down or cool down, there will be accumulation of lactic acids, which actually causes soreness in the muscles after activity. So if we were to perform proper stretching exercise, we will reduce the instances of muscle spasm, thereby reduce the instances of more muscle soreness and fatigue.
Okay. This question says that she has a patient with a disc tear. Can exercise help to reduce the pain?
All right. From this tear, I would assume that it is a tear in the disc, and which either cause a prolapse of the nucleus pulposus, or there is no prolapse, just a tear. And sometimes this tear, when there is a prolapse, will either cause compression or impingement on any of the nerves, which can give rise to radiating pain down the muscles of the leg, or maybe localized pain. So it will depend on where is the tear. Okay. Is it a posterior tear, a posterior lateral tear? Because if it is a posterior tear, then maybe exercises in extension will help to reduce pain. And also therapy and massage will definitely help to soften the tissue around that area, prevent more compression on any of the sensory nerve endings. It will definitely help to relieve the pain. And also if it is a prolapse, by doing Mackenzie exercises, in extension, we will help to reduce if there is any prolapse that is pressing on the nerves. So Mackenzie exercise will be good if the tear is giving rise to pain due to compression by the nucleus pulposus. So these are the exercises which is advocated for with disc tear.
You mean, Sufan, on this disc tear, you also depends on which part of the disc it is torn, is it?
Yeah. Usually,
Okay.
if it is anterior, there will be no sign at all because there's nothing that will be compressed by the prolapse. But if it is posterior and posterior lateral, especially posterior, that is when the compression of the nucleus pulposus on the nerve that will give rise to radiating down the leg, or what we call the sciatic pain, you see. So there are some form of exercises which can actually relieve this compression.
Okay, thank you. It is quite expected that with icing only initiates vasoconstriction at skin level and vascular tissue is spared, as there is no effect on muscle. Your thought on this? Did you get what I'm trying to say? I read the question again. I can't find myself too. All right. It is quite expected that with icing only initiates vasoconstriction at skin level and vascular tissue is spared, as there's no effect on muscle. What's your thought on this?
Okay, I think in my talk I mentioned that when you apply ice, the effect mostly is quite superficial. It is very difficult for it to go into the deeper tissue because of the fat content. And for it to go deep, you have to apply ice maybe for a very long period of time. So that is the meaning of vasoconstriction only happens at the superficial layer of the skin. So the muscles and all this, of course, the coolness of the ice is not affected. I think that's what he meant, right? So I would think that it does not go deep. The icing does not go deep, okay? Unless you do it for a long period of time, then slowly the coolness will actually go down to the muscular level. That's why we come up with the argument to ice or not to ice, okay? So if ice is found to be only superficial, it actually makes the patient feels comfortable, relaxes the patient, and reduce the pain, the pain sensation. So that is the effect of ice. It doesn't reach the muscular level.
I think
yeah.
Thank you for your answer.
Hope it answers.
In fact, not only on this, even the change of the paradigm and change on the approach of treatment or in therapy or in training, there has been a lot of changes, all right? Like in musculoskeletal, they used to have a problem on the atrophy of the medialis muscle that causes knee pain. Some say no, some say correct. Now the rise has changed into price and police and so many others. In my opinion, over my years of practice, I think whatever that works for you, it all serves a reason for that with the science behind it. All right. Okay. I think Sufan, you will have to answer them, or they will get you will type your answer here. For those people, I know there's a lot of requests onto the speakers' slides. So what we do, you can actually go through the paper again on the YouTube. We will load it up onto the YouTube. Okay. So Sufan, we have about 2 or 3 questions. I think you have to answer them outside onto the into the chat box or the question and answer group. Okay. All right. Thank you very much, Sufan.
Okay.
All right. We'll come to the next paper. This paper is a colleague of mine, Professor Zom. University of Physical Education, also a colleague of Dr. Burkesh. He is the director of the Institute of Sports and Health Sciences at the university, an orthopedic surgeon specialized in regenerative medicine solutions, founder and the CEO of OrthoSera, right? His research aimed at the regenerative serum platform that can be used in multiple degenerative diseases. So I'm very glad you can join us. I know at the university you are extremely busy. So thank you very much. The floor is yours, Professor Zombo.
Thank you. I guess you hear me. I'm trying to share my slides with you. Just a sec.
I think Dr. Zombo is having some technical problem to turn on his slides. Just bear with us for a few minutes. I think here he is. Here he is. Professor Zombo, are you okay?
Yes, thank you.
Okay,
I am okay.
great. Okay, good. All yours.
Rejoin the conference in order to share the slides, but now it should work, and it does. Okay, you see my slides then? Okay, thank you. I see you then. So this is, my name is Zsombor. I am the Vice Rector for Science at the University of Physical Education in Budapest. And I work for the university and both for Orthosera as a small startup company. And this is a sunny and very cold morning here in Budapest. And first, I would like to share a little bit about the landscape of orthopedic regenerative medicine, and then we go deeper into the details of some aspects. First, most of the diseases that we treat are degenerative joint diseases like knee osteoarthritis, like in this picture. And there are roughly 3 types of treatment regimes. One is drugs. The other one is physical-chemical means, and the third one is biologics. And if you go a little bit deeper into that, you can see that the trends are going against the drugs. So basically, we prescribe less and less drugs. I don't recall when was the last time I prescribed drugs, maybe once at every outpatient clinic or even less. Now, physical-chemical is also declining because the efficacy is questionable and the clinical cost-benefit is not too good, like lavage and debridement by arthroscopy. And the biologics are emerging, which is a good news for us who are doing research in this area. But, and we do a lot of studies on the biological efficacy, but the clinical cost benefit is, well, unknown or not very good. There are a few key differences in the diagnostic needs as well. So the physical chemical treatments need a simple X-ray and nothing else. If you want to prescribe drugs, especially for rare indications or special sub-indications in these degenerative joint diseases, then you have to do, you know, like special diagnostic tests, lab tests. But the worst comes here when you want to do biologics, you need to do quite a lot of different diagnostics. And these are MR, CT, ultrasound, advanced X-ray techniques. You also have to check muscle imbalance and inflammation markers, biomarkers, quite a lot of things in order to make your biologics more effective. So what are the protocols? Physical chemical means like hyaluronic acid injections or arthroscopy. The protocols are simple and they are already in the routine of most physicians. Like if you want to treat these patients with drugs, this is typically the conservative treatment regimes, rheumatology treatments, physiotherapy treatments. And for the protocols of biologics, again, they are the most varied from all. So you have ultrasound-guided injections, for example. You have regenerative surgery. You need to have cell isolation. You need to have a tissue bank in order to perform these. So this is quite a complex thing. But eventually, these things fail roughly in this order, and in the end, you will go into joint replacement anyway. So this is the full landscape. This is what we have. And this is what my colleagues who are doing general orthopedic practices do. Well, not much out of the full landscape. This is what a rheumatology practice or a wellness medicine practice does, mainly conservative treatment and only focusing on a subset of possible treatments. And this is what regenerative orthopedics or typically sports orthopedics practices do. So you can see that although we are treating the same type of patients, the landscape is so varied that people are focusing on one or the other group of treatments. And last time when I was talking at this conference, I was focusing my talk on the complex diagnostic needs, especially the muscle imbalance and the inflammation markers for biologics. But today I will talk mainly about the biologic treatments. And I think it is quite useful for this audience, as you will understand what us physicians do for your patients with these complex biologic treatments, what can we achieve and what can we not achieve. Okay, so the biologics are usually these little green blocks, but typically they consist of three major types, like they can be either cells or signals or scaffolds. But what are biologics in general? Now, the biologics are basically everything that act on the cells or tissues in a similar mean how they behave. For example, cellular components, secreted factors, inflammation markers, the extracellular matrix molecules like collagen, physical factors, meaning shear stress, or even the specifics of the surface, and of course, metabolic factors. They are all in, and the stem cells sit in the middle because these are the cells that provide most of the factors. These are the cells that will turn into new cells. They generate the extracellular matrix, so they are the centerpiece of all. But first, let's talk about the simplest of all three. These are the scaffolds. So what is a scaffold? A scaffold is a simple thing. It's just a frame to climb onto. And it must fill the void until a tissue grows in. And it is basically a glorified spacer. So if you are a surgeon and you put in some kind of scaffolding, for example, a collagen sponge into a tissue hiatus, then this will serve as a matrix, which is basically a scaffold for the cells to grow onto it and then eat it up and then turn it into real tissue. Of course, there are smart scaffolds that create an optimal environment for this regenerative niche, and they direct the cells toward the preferred lineage. Like, for example, if you are implanting it into muscle, that the cells turn into muscle, or if you are implanting it into bone, then calcification is of course needed. Some smart scaffolds provide critical minerals and nutrients for the cells to grow faster, and there's a lot of research going into optimized geometry and the pore size to generate the right kind of tissue. And of course, optimized cell surface characteristics for cell attachment is also important. Now, what is going on in the research and what is going on in the clinics? Last time I checked in PubMed, there were close to 50,000 PubMed papers on tissue scaffolds. That's a lot. That's a huge number. However, these smart scaffolds typically never get into the clinics because they are so complex that they cannot really pass the regulatory barrier. So, for example, even alginate, maybe you know alginate. This is a simple gel generated by algae and can be used in, for example, wound dressings. But you cannot have a GMP level source of it, and that's why you cannot implant it into, for example, soft tissues. So toxicology is a big thing with these tissues, especially if they contain anything which is labeled nano or nanotechnology. So that's why I think it is It is a good idea. It's a very nice research topic. However, it is very complex to. I hope that these messages don't come to me. Yeah, probably not. So these scaffolds are very nice in research, but they almost never get into the clinic. So what is getting into the clinic? The best scaffold is human tissue because it has the ideal material composition. It has the ideal geometry. It's easily harvestable, so you have plenty of human bodies which are disposable. It has a known metabolism, and luckily it is unregulated, which really means that there are a few issues with it, but human tissues are typically very good scaffolds. Like there are a few problems with the ethics of harvesting. For example, can you use live donors for bone material, which restricts your possibility to harvest bone, or you are doing it from deceased patients. But by and large, it is working quite well. This is the picture of how it looks like. So this is a piece of human bone processed for human implants. It is quite nice, clean, packaged, can be stored at room temperature for up to 5 years. So this is a nice product. And in this enlarged picture, this is an electron microscopic picture of one of the pores of this bone. And in this case, already stem cells are grown onto the bone. And in the middle, you can see a stem cell spanning the void and then sitting in the hole in the bone. So this is a really nice type of scaffold. And just very briefly, I show you our work on how to generate this type of scaffold all the way from basic science to the clinic. So already in 2006, we had the data that showed that albumin impregnation of this simple bone is increasing stem cell attachment. Then we put it into animals. In 2011, there was the first human studies in prosthesis revision cases. You can see this is a knee prosthesis device, and the surgeon points to a fairly large piece of bone that is being implanted with, which is our bone albumin scaffold. And then we did several studies in different types of knee surgery, also in dentistry. And since 2015 or 2016, we are selling it to dentists and also generating more and more data. And as you can see, it took us 10 years to get from the basic science all the way into the clinic, although it is a simple therapy, but at least it works quite well.
Okay.
This is about scaffolds. And as you can see, scaffolds are quite good, but they are not good enough for most indications. For example, if you are only using scaffolds, you can replace bone, which is nice. But for example, there are no clinically usable scaffolds for muscle. There are no really good scaffolds for replacing a tendon, let alone nerve tissue, either peripheral nerves or even the brain. So you need something more.
Excuse me.
Go ahead. Somebody is saying something. Okay, so that's not for me. So let's talk a little bit about cells. So if you have the scaffolds, sometimes you need to load them with cells. So what is the logic of cell therapy? If you lose a tissue, then you need to replace them. If you have tissues to grow from cells and you give them the cells, they will regrow the tissue. It's very simple. So basically, stem cells can fill the hole in any tissue. However, it was the idea like 20 years ago when I started working with that. But nowadays, it is getting a little bit more complex. For example, bone marrow-derived mesenchymal stem cells, which are the typical stem cells, have been discovered first, and they are widely used in research. Their physiological role is divide and conquer, meaning that they make unlimited divisions and they can turn into any type of tissue in the body. And they are typically the first choices in clinical studies. I myself participated in studies with these and they are routinely used in human therapy, well, in special centers. But the problem with these cells, and this is how they look like, and this is the classical picture from 1988 that shows how a mesenchymal stem cell can turn into bone, cartilage, muscle, and so on. However, they are not really stem cells at all in vivo, because what you have seen in the picture, it is in vitro, so basically in the lab, but in vivo, these cells are not really differentiating into any cell types, and they are mainly pericytes. So these little cells which are sitting on the outside of the capillaries, and whenever there is an injury, they break and they turn into little cells that that make lots of paracrine factors. And these paracrine factors then activate other cells to grow into the tissue. So this is getting much more complex than we initially thought. And this is coming from Arnold Kaplan as well. So in 20 years, he also changed his mind about that. So there are adipose stem cells on top of that. And adipose stem cells are multipotent. They can easily be harvested from fat. And as you know quite well, there is plenty of fat tissues around in patients that can be harvested. And then it's easy to harvest. And there is a fairly reasonable scientific basis in vitro that they can replace mesenchymal stem cells in therapies. However, they share all the problems that the mesenchymal stem cells do, so probably we can't really use them to grow tissue back into their own shape. And there are these which I simply call Frankenstein cells. So all kinds of different cells which are manipulated, because the mesenchymal stem cells or the adipose stem cells are not really manipulated. You just harvest them and use them. But if you want to improve them, then you can modify them. For example, there is a company in Israel which is doing pig cells, and they are trying to turn them into usable cells for human brain disorders, or embryonic cells. Embryonic cells are quite pluripotent and easy to grow. However, I mean, you can put it very simply and bluntly, you have to kill a baby to cure old people. So that's not really an ethically approvable method. The induced pluripotent stem cells, which have generated quite a lot of interest recently, especially after the Nobel Prize for the Japanese colleagues for it, can be done from any kind of stem cells, and they can be turned back to pluripotent stem cells. But then again, you end up with cells which look like mesenchymal stem cells, and we had them from the beginning, and we cannot cure much with them either. Of course, genetically modified cells are probably the best. There is plenty of research showing that you can modify the cells genetically, but I don't see that in the near future any of these cells will make into the clinics, especially not in major indications like osteoarthritis. So these things are very nice and very interesting, and there is quite a lot of research into it, but unfortunately most of these will never be applied in real patients because of ethical issues, toxicology issues, and simply regulatory hurdles that they cannot pass. However, there is a great interest in the public, and as you can see in these two pictures, these are both from the United States. One is a clipping from a newspaper where they freely advertise stem cell clinics for probably knee pain. I don't know what kind of stem cells and how would they apply it, but I don't think that with these $1,000 coupons, it is a valid therapy. Or in the other picture, you can see that on roadside pictures, physiotherapists are advertising stem cell injections with their knee pain tactics. So it is a problem, and there are about 100 new illegal stem cell clinics opening every year in the United States, and FDA are closing them, but they cannot close them fast enough, so the new ones are opening up. So this is an issue. Please be aware of it. And if you have patients coming to see you after stem cell therapy, or especially after a failed stem cell therapy, be aware that maybe they participated in some of these schemes and they may have not gotten anything close to a stem cell therapy. So this is a problematic issue. So let's talk a little bit about signals, which is probably the best of the best approach out of the three main types. What are these signals? These signals are typically growth factors, which act in a nanomolar range, so they are very, very potent. They are secreted by cells, one cell to act on another cell nearby. So they are not hormones, they are not circulating in our body, they are circulating locally in the tissue only. So one cell making a signal to the other cell through factors that they secrete into the extracellular matrix. And they are the key mediators of development, tissue turnover, and healing. So they are basically quite good, optimal drugs. However, it's not easy to use or find these cells, to these growth factors, but you can find quite a lot of them in blood serum. So why? When blood is activated, it contains lots of growth factors, mainly coming from the platelets and the white blood cells, and they have a natural mix for healing. And this is how it actually works. So in the acute healing process, there is an injury, there is bleeding. When there is bleeding, there is coagulation, platelet activation, and the platelet activation generates quite a lot of growth factors into the surrounding area, into the serum, which results in healing. If there is a chronic injury or a repeated injury, there is chronic inflammation, there is pain and dysfunction on the right side of the figure, and there is impaired healing and degeneration. This is going on, for example, in a tendinosis, but also in osteoarthritis. So if you harvest, theoretically, the fresh serum from an acute healing process and implant it into a chronic degenerative process, you may even reactivate this impaired healing into a complete remodeling, and that would be a good idea. So this is the idea of growth factor therapies and blood-derived therapies. So serum turns the chronic degeneration cycle into acute healing. How can it be used? Typically, in any degenerative disease where healing is slow or healing is stopped and then there is a chronic problem. And for example, I just listed here those which have fairly good scientific evidence in the clinics. From top to bottom, there is male alopecia, there is wrinkle filling in aesthetic dermatology, there are these typical tendinoses like the tennis elbow, osteoarthritis mainly in the knee, and also wound healing, even chronic wound healing. So these are the areas where we have plenty of evidence that these therapies actually work. Now, this is a big figure and I don't want to go into the details now, but these sera contain quite a lot of active factors. We measured more than 200 and we haven't seen most of them. So in this picture, we have also compared different types of serum and plasma and PRP and SPRF. And what we have seen is that although the isolation method of these blood therapies are fairly similar, their composition is very, very different. If you just look into, for example, the panel B, you can see that the black bars are very high, which show that these pro-inflammatory cytokines are very much increased in platelet-rich plasma. However, they are much less in the red bars, which are serum from hyperacute serum. So that's a good distinction. For example, if you want to have a blood serum that is inducing inflammation, then you should use the black bar like PRP, or if you want one that is blocking inflammation, then you should use hyperacute serum, which is the red bar. If anybody is interested, I can give you the papers and we can discuss it in more detail. This is just a summary. For example, if you put serum into an inflamed osteoarthritic knee, what does it do? Based on the data that we collected from a clinical study, it seems that the inflammatory proteins and the anti-inflammatory proteins lean towards the anti-inflammatory part, tissue degradation products and MMPs are going down and tissue remodeling markers are going up. So basically, if you inject hyperacute serum into a joint, there is some kind of remodeling going on, and then it is coupled with an anti-inflammatory action. If you put the two together, that means that probably there is a pain reduction in the patient and maybe some kind of improved regeneration. So the take-home message from this talk is that regenerative therapies are out there. They are used widely in regenerative medicine, especially in the musculoskeletal field, orthopedics and rheumatology, and you will see more and more of these. Out of the three main factors like scaffolds and cells and signals, cells are very cumbersome to use and probably they are not really needed. Scaffolds are widely used, but only natural scaffolds like bone tissue or collagen are truly applicable in a clinical field. And then signals like blood sera and serum derivatives are those that are most widely used, and they can be probably the next wave of non-surgical methods for improving degenerative diseases in the joints. And if anybody is interested, we are open for research cooperation in this field. Thank you very much.
Thank you, Dr. Zombo. Good, an excellent paper. It's interesting to know. I have a questions for you though. You see, I have been exposed and actually to a lot of papers and articles on the topic of stem cells treatment. Of course, a lot of them have used stem cell in the aesthetic industry. In terms of injuries, let's say, for example, you have a meniscus injury, right? And I believe that there are some, I think there are 1 or 2 centers in my country that they don't do any more arthroscopic. They don't even clip off the debris of the torn meniscus. They just administer stem cells on it. What is your opinion on that? Do they need to clear debris of the torn meniscus by arthroscopic and then administer the stem cells, or they just administer the stem cells? What's your opinion on this?
The thing is that there is some evidence that if you are filling up the hole in these torn menisci, will help. Whether with stem cells or serum derivatives or growth factors or even just some gels, like collagen gels, there is not enough any evidence yet to tell. But what we do know is that if you just do a debridement, so you take out the torn parts of the meniscus, it will help in the coming like 3-4 months, and then it will degrade faster. So that's not a good idea. And then, although it is a very simple procedure, it is easy to do, fairly cheap. And this was the routine like 20 years ago. It is still the routine in quite a lot of centers, but it's not advisable anymore. But filling it up with stem cells is very cumbersome. As you have seen in my talk, it's a complex thing. And since this is too complex, quite a lot of surgeons don't want to do that.
Oh.
And reimbursement is not there for the procedure yet.
Okay.
And,
how much is
it is forbidden in some countries? So it's an issue. I think this is the way. You can even do it closely under ultrasound guidance, for example. So this should be a very nice way of moving forward, but there are quite a lot of work ahead of us.
Okay. Is this expensive for a knee injury?
It is. It is much more expensive than an arthroscopy because you need to isolate the stem cells.
Oh, yeah.
And it will, and also it will cost you work. So it's not just the expense, but also that you need to buy the equipment, learn how to use it, put it into the OR. It's quite cumbersome.
Okay, thank you. All right, good. Any questions from the floor? We have close to 300 people attending. Any questions from the floor?
Good.
Good. All right. If there's no questions, if there are any questions, Dr. Zombo, we will forward the questions to you via email. All right.
Perfect.
Thank you very much. It's such a pleasure to meet you again. Bye-bye.
Definitely. Thank you.
Yeah. All right. So we're forward to the next speaker. Oh, this is from Japan. Mr. Kentaro Esaki. All right. Hi, Kentaro. How are you doing? Good. Mr. Kentaro and us has been doing some program together in Malaysia. And I'm not going to be biased or anything. All right. He is the founder of the Esaki Medical Instruments in Japan. He graduated from the University of Sunshine at the coast in Australia. Right. And of course, he's running the Esaki Medical Instruments and specialized in manufacturing, distribution, and marketing of the medical instrument, in particular rehabilitative. Right. So his paper today is various resistance exercise types and technologies. Okay. Kentaro-san, I have the floor for you now. Thank you.
皆さんこんにちは。江崎機械株式会社代表の江崎健太郎と申します。本日は Various Resistance Exercise Type and Its Technology という題で発表させていただきます。まず、レジスタンストレーニングについて簡単に説明をしたいと思います。レジスタンストレーニングはその名の通り、筋肉にレジスタンス、抵抗ですね、をかけて筋力強化を目的として行う運動のことを指します。昨今、コロナウイルス感染症の流行によって、国によってはロックダウンをしているところもたくさんあるかと思うんですけれども、そんな中で運動不足によって筋力低下が非常に起こっているというのが問題になっています。人間の筋力というのは安静状態ですと1日で 0.5% 失われると言われておりまして、1年で 1% と言われていますので、20歳を過ぎると 1% 失われると言われていますので、非常に大きな損失というふうに考えられます。ですので、レジスタンストレーニングをうまく行っていただくことで筋力低下を防いで、非感染性疾患 NCD のリスクというのを下げるというのも非常に重要になってきます。で、私の発表の中で様々な機器ですとか技術ですね、レジスタンストレーニングの機械の技術なんかについて説明をさせていただきますので、家庭でトレーニングをされる時の助けになれば幸いと思います。で、まず、レジスタンストレーニングを簡単に分類したいと思います。まず、自重を使って行うのか、もしくは負荷を使って行うのかの2種類に分かれます。その中で、自重を使って行う場合でも、装備を使う場合ですね。例えば、サスペンションを使う場合、プルアップバーなどの器具を使う場合、エクササイズボールなんかを使う場合、というふうに分かれます。一番簡単な自重トレーニングですと、もう何も使わないでスクワットをしたり、シットアップ、プルアップなんかを行うという方法もあります。負荷を使う場合ですと、主にマシンを使う場合とフリーウェイトと言われるような重りを使ったトレーニングに分かれると思います。その中でもバーベルやケトルベル、チェーンを使ったトレーニングなどや、マシンを使う場合でしたら、ウェイトスタック式、油圧式、マシンの中でも様々な負荷方式があります。で、今回はマシンの負荷方式について主に説明をしていきます。まず、負荷をかける方がいいのか、自重を使った方がいいのかという質問なんですけれども、自重を使う場合ですと、下肢に対しては非常に弱く、もしくはチニングなどのトレーニングにおいては負荷が強くなるということが考えられます。下肢の場合ですと、スクワット、自重で行うスクワットだと、負荷があまりにも軽すぎて、いいレジスタンストレーニングはなりませんし、チンニングの場合ですと、女性には特に負荷が重すぎて、1回も上げられない。この動作ですね。上げられないという方が非常にたくさんいらっしゃいます。ですので、重さをかける、重りをかける、マシンを使う、もしくはフリーウェイトなどの調整式の負荷を使うというのが、レジスタンストレーニングにおいては非常に重要になってまいります。では、負荷をかけることに対してどういうリスクがあるのかというのを見ていきたいと思います。これは、ベンチプレスをされている方の事故の例を動画に撮ったものです。そして、下の動画は、レッグプレスで膝関節が反対方向に曲がるという事故ですね。 このチェストプレス、ベンチプレスですね、の事故、レッグプレスの事故というのは非常に多く起こっておりまして、ベンチプレスの方は死亡事例もたくさんあります。また、レッグプレスの事故に関しても、私もここ1年以内で1件実際に見たことがあります。そして右の写真なんですけれども、これは私が数年前にバーベルスクワットをしていた時に補助なしでやっていたんですけれども、その時に誤って転倒してしまい、体がバーベルと地面に挟まれたことで、胸椎の12番と腰椎の1番が圧迫骨折をしてしまったと。こういうような事故事例があります。ですので、エキセントリックの筋収縮っていうのはリスクになりやすいということをまず覚えておいてください。これから5つのマシンと装備について説明をしていきます。ウェイトスタック、ハイドローリック、空気圧、モーター、電動アシスト、サスペンションなんですけれども、双方にコンセントリック、エキセントリックで負荷をかけられるか、筋肥大の効果がどれだけあるのか、怪我のリスクがどれだけ高いのか、値段がどれだけ高いのかというのを表にしております。そして、コンセントリックコントラクションのことを少し説明をさせてください。これは、大腿四頭筋の例にとって説明をしますと、力と可動域で説明をすると、しゃがんだ状態、この場合は筋肉が一番、大腿四頭筋が伸びた状態が一番弱く、立ち上がる直前、関節で支えるまでの立ち上がる直前というものが、大腿四頭筋の筋力が一番強いという状態です。ですので、コンセントリックコントラクションの場合は、筋肉が伸びた状態が一番弱く、筋肉が縮まった状態が一番強いというふうに覚えておいてください。では、ウェイトスタック式の方の説明をしていきます。ウェイトスタックは、エキセントリックとコンセントリック、両方の負荷を、単一の筋肉にかけることができます。フリーウェイトと比べて、動きがコントロールされていますので、安全性は高いのですが、先ほどのレッグプレスのように、関節可動域を伸ばしきったりすると、事故の危険性というのは稀にあります。プーリーとベルトという構造を使えますので、例えばテコの原理を応用して、例えば5キロの重りで10キロの負荷を出す、2.5 キロの重りで10キロの負荷を出すというような、軽くしながらも負荷を大きくということも、可能です。ただし、他のマシンに比べると実際に重りを取り付けますので、1台あたりの重さが数百キロになる場合もあります。特に1対1の重りを使う場合は非常に、重さが重くなるというのが特徴です。ですので、あまりホームユースには向かないかもしれません。また、ウェイトスタック式において、どういうふうな原理で行われているのか、そして、筋肉の構造をどういうふうに考えて作ったのかというので、いい例がアーサー・ジョーンズ博士が作ったノーチラスカムというものがあります。これは実際に特許を取られている技術なんですけれども、先ほど言いましたように筋肉が伸びきった状態はコンセントリックは弱く、縮まった状態が強いということで、可変抵抗というものをウェイトスタックマシンに初めて取り入れたマシンがノーチラスというマシンになります。非常に優れたシステムです。次に油圧式のマシンについて説明をします。油圧マシンはコンセントリックコントラクションしか筋肉に負荷をかけられません。その一方で一つのマシンで2つの部位に負荷をかけるということができます。例えばショルダープレス。重りの場合は下げるときにはエキセントリックの負荷ですが、油圧式のマシンの場合は下げるときはラットプルダウンの動きが可能です。ですので、一つのマシンで二つのマシンの動きというのをかけることができます。で、エキセントリックの動きがありませんので、重りの負荷に比べて安全性は高いと言えます。ただし、オイルの粘度ですね。ビスコイラスティというものが温度によって変わりますので、夏に使う場合と冬に使う場合は負荷が変わったりですとか、動き始めと1時間使った後は当然油温がオイルの温度が変わりますので負荷が変わるという特性があります。 重さに関して言うと非常に軽く作っているので、ホームユースでも優れていると思います。では、油圧シリンダーについて簡単に説明をします。このダイヤルを回すことで中にあるオリフィスというものが閉じたり、開いたりすることで、流れる油量を調整する。それで負荷を変えることができます。では実際の構造を簡単な略図に表してみます。青い矢印の方向にシリンダーのピストンを押すと、左の部屋から右の部屋にオイルが流れようとします。この時にオリフィスと呼ばれる弁を開いたり閉じたりすることで、油量の調整をしています。オリフィスを開けば当然流れるオイルの量が多くなりますので軽く、オリフィスを閉じれば少なくなるので重くなります。ただしオリフィスをオイルが通るときに摩擦熱が生まれますので、この摩擦熱がオイルを温めることで粘度が落ちて抵抗が変わるというのが特徴です。では次に空気圧の説明をします。こちらのマシンはエキセントリックのコンセントリック両方の負荷をかけることができ、また一つのマシンで2つの部位も鍛えることができる。先ほど言ったようにショルダープレスとラットプルダウンがエキセントリックとコンセントリックの両方でかけられるという非常に優れたシステムです。ただしマシン単体で動かすことはできず、コンプレッサー、エアコンプレッサーという空気を圧縮する機械が別に必要になってきます。またエアコンプレッサーを使用する関係で湿度というものが非常に影響を受けます。ですので、もともとこのマシンが開発されたアメリカですとか、フィンランドなんかは空気が非常に乾燥している地域でエアコンプレッサーにダメージが少ないのですが、アジアの地域ですとエアコンプレッサーに当たるダメージっていうのが非常に大きくなるので、その点には注意が必要です。では、実際どのようなダメージがあるのかと言いますと、このように圧縮した空気を溜めるタンク内が水分で錆びてくる。ですので、水抜きと言われる行為をすると、このように錆びた水が出ることがあります。また、この錆びた水、湿気を帯びた空気というものが、ダイヤフラムポンプという部品を傷めることで、故障の原因にもなります。ですので、もしコンプレッサーを選ばれる場合は、ドライヤー付きのコンプレッサーを使われることをお勧めします。では、空気圧シリンダーの構造を見ていきたいと思います。エアコンプレッサーで空気圧を高めて、アキュムレーターという部品にその圧を溜めます。例を表すと、注射器に風船をつけて、その注射器を押すと、アキュムレーター、風船がアキュムレーターですと、そのアキュムレーターが風船が膨らみます。そして離すと元に戻ります。で、この風船の中に溜まっている圧を上げるのがエアコンプレッサーだと思ってください。青い矢印の方向に、シリンダーを押していくと、左の部屋に入っている空気がアキュムレーターのところにつながっているので、アキュムレーターに圧が集まりながら、押し返す方向に抵抗がかかる。というふうな具合に負荷を調整できると。で、ダブルアクティングという複動式のシリンダーを使う場合ですと、空気を入れる穴を位置を変える。例えばこれを右の部屋に空気を入れることで、今度は反対方向に力をかけるということができます。非常に優れたシステムではあるんですけれども、高価なのが難点です。では次にモーターを使った負荷です。これはいろんな構造があるんですけれども、エキセントリックだけをかけるもの、もしくはエキセントリックとコンセントリックの両方の負荷をかけ、なおかつその両方の負荷を調整ができるというシステムです。エキセントリックっていうのは、筋肥大の効果っていうのがコンセントリックよりも高いというふうに言われているので、このようなマシンを作られたというふうに聞いていますが、非常に複雑なシステムのため、動きを理解するまでに、トレーニングを行う人がかなりの慣れが必要になってきます。また、非常に複雑な構造ですので、機械が高いのも特徴です。よく一般的に言われるのが、負荷の調整が非常に複雑に厳密にできるのですけれども、やっぱり調整が面倒だという、お声が非常に多かったです。優れたシステムはあるんですけれども、そういった声もあります。 では、次にアイソキネティック、電動アシスト負荷というものです。これも、コンセントリックの方向にしか、負荷をかけることができません。モーターを使って、スピードをコントロールしているので、厳密な、等速性筋収縮アイソキネティックの運動というのが可能になっています。このシステムの優れている点というのは、その日のコンディションですとか、筋肉の、特性ですね。先ほど説明した縮まっている時に強く、伸びきった時に弱いという負荷というのを無視できるというところが非常に優れた点です。ですので、特に何も調整せずに全力で押して引いていただくことで、その時に合った筋肉の位置によった最適な負荷が筋肉にかけられるというのが優れたところです。もともとサイベックスというマシンが等速性筋収縮運動のマシンとしては一般的だったんですけれども、値段が非常に高く、導入事例というのがあまりありませんでした。しかし、弊社の私どもの開発した電動アシスト負荷っていうのはコストを10分の1以下まで抑えることができましたので、非常に導入がしやすく、運動効果も高く、また安全性も高いということで、非常によく売れております。では実際にアクチュエーターというのはどういうものかと言いますと、こういうような構造になっています。この部分にDC モーターが入っていまして、中にギアが入っています。で、モーターが回ることで、この部分が伸びたり縮んだり、そしてそのスピードがモーターによって厳密に一定にコントロールされているというのが特徴です。で、この機械の部品というのは、例えば医療のベッドですとか、例えばアメリカのボーイング社の飛行機の羽を開け閉めするシステムなんかにも軽量化のためにこういう仕組みが取り入れられています。非常に力が強く軽いのが特徴です。この電動アクチュエーターでだいたい200キロ、250キロぐらいの負荷を支えてることができます。じゃあ、一体どのようにアイソキネティックというものが働くのかというのを見てもらいます。これはレッグプレスというマシンですが、この状態から軽く蹴ってみると、だいたい30キロから40キロぐらいの負荷ですが、力を入れてできるだけ早く動かすと、負荷が一気に120キロが130キロまで上がります。これは実際オーバーロード、体重計の測れる速度以上に測ろうとしているので、135キロ以上は出せないんですけれども、例えば体重計を2個乗せれば、理論値的には200キロぐらいの負荷をかけることも可能です。このように何の調整もしなくても負荷が簡単に自身の負荷によって変えられるというのがアイソキネティックマシンの優れた特徴です。で、最後にサスペンショントレーニングについてもご説明をします。こちらもコンセントリックとエキセントリックの両方の負荷がかけられます。自重のトレーニングなんですけれども、使い方を工夫することでいろんな部位に負荷をかけることができ、なおかつストレッチを行うことも可能です。負荷というものも自重で行うよりは簡単に変えることもできるので、ホームユースのトレーニングとしては優れたシステムだと思います。ただし、天井を補強する必要があります。というのはサスペンショントレーニングっていうのは天井からロープですとかを吊るす、もしくは壁にロープを引っ掛けて使うという特性上、そういうことは弱点として挙げられます。最後にまとめます。エキセントリックコントラクションというものが、先ほどもお伝えしましたように、レジスタンストレーニングにおいては、最大のリスク要因になります。ですので、このリスク、怪我のリスクをですね、どのようにして減らしていくのかというのが、ホームトレーニングにおいては非常に重要になってきます。昨今のコロナウイルスの流行下において、医療崩壊というのが始まっていますので、家でのトレーニングというのは非常に有効なんですけれども、怪我をしてしまうことで病院に行けないというようなことも考えられますので、怪我のリスクを減らしていただくというのは非常に重要になっています。ですので、重要なのは誰かと一緒にトレーニングをする。 特に、エキセントリックの負荷を使う場合はですね、誰かと一緒にトレーニングをしていただく、誰かを見守る、サポートをする、サポートしてもらうというのが非常に重要になってくるかと思います。もし、若い方、20代から40代ぐらいまでの方が、家でレジスタンストレーニングをされる場合は、おすすめは、フリーウェイトですとか、サスペンショントレーニングを組み合わせていただいたトレーニングを行っていただくのが良いかと思います。65歳以上の高齢者の方が筋力低下を防ぐためにレジスタンストレーニングを行う場合は、アイソキネティックマシンや油圧マシンを使ってトレーニングを行っていただく、サスペンショントレーニングを椅子を使って行っていただくなど、十分に注意しながらレジスタンストレーニングを行っていただくと良いかと思います。それでは発表を終わります。ありがとうございました。
Thank you very much. I may not understand Japanese.
No.
But anyway, your paper actually clears a lot of light because over the years, in particular in the early 80s and 80 onwards, in 1980s onwards, the market, the industry in exercise equipments, they were mounting up. We see Polaris, we see the cam system, we see so many systems that comes in here, then comes in with the cable, so many, and different has its own reason, and that's why your paper will give actually a very clear idea on people how to choose equipments for specific training, right? So thank you for your paper.
You're very welcome.
Yeah. All right, we're going to open this for questions. Is there any questions from the floor? Kentaro-san can actually speak English.
I think so.
Yeah, I'm sure you do. Yeah. So if there's any questions, you can type here. All right. If there is none, we can also get, if you cannot think of any questions right now, we can also get you Kentaro's email, and you can forward your questions to him. For your information, Kentaro-san actually manufactured an equipment that is very useful. We have seen. All right. Oh, I have a question here for you. Which is best between isometric, concentric, and eccentric for strengthening and rehabilitation?
So it depends how it works. It's probably which is the best between isometric, concentric, and eccentric. Yeah. For me, for my understanding, it's isometric. It just pushing a wall or something, and the muscle don't contract. So actually, for the rehabilitation, I recommend concentric or eccentric. That's a joint moving. It is very important. So I think the best for the rehabilitation that if you're supervising it, combination with the concentric and the eccentric is the best. But no supervision or something, maybe that's you're just using concentric is much safer.
Good. I think that's a very conservative answer to the question. I would like to add a little bit to this. I think your questions that which one is good, which one of the types of contraction is recommended for injury. If you recall Sufan's paper just now on exercise and injury, she has a particular advice that it all depends on the type of injury that is required. Right? I think if you look into neuromuscular, as I'm aware, as I know, neuromuscular type injury, it is good to use the eccentric to trick the loop, the efferent and the efferent pathway. All right, so it all depends on your type of injury. Okay? Thank you, Kentaro-san. One more question: can concentric only exercise be used for bodybuilding purposes? This must be a bodybuilder.
Actually, no. It's actually that's some bodybuilder likes to use the hydraulic machine for the pump up before the show. So they just using it, really fast for the hydraulic machine to pump up to make your muscle looks better, bigger. That purpose. But if you want to build up your body, concentric only doesn't work very well. Probably, combination with the concentric and eccentric works much better.
Yes. And over my experience back in the 80s when I was working for Joe Wader at the Wader Corporations in the United States, I have been exposed to the Mr. Olympia, Lee Haney, people like Richard Gaspari and so forth. As far as bodybuilders are concerned, they use the holistic approach. They use anything that increase muscle size. Eccentric generates greater force. Greater force can build greater muscles and muscles composition, white and red tissues. You use different types of approach. So true, bodybuilders, they use all kinds of approach to build a muscle. Right. There's one more question here. I saw kinetic exercise speed is constant. How much effort should we ask the patient to push the equipment? Because even light push can push the equipment.
Yes, this question is every time lots of physical therapists ask me about this question. So normally I tell them my trainees to push as fast as possible, so that they push. Actually, that the machine won't move faster, but they push really fast. So that's the muscle contraction will be probably 70 to 80 repetition maximum, 70 to 80% of repetition maximum. Very good training. And yes, you can push by one finger, for example, the chest press, and maybe they don't push really hard. So we need to check sometimes we just, touching the bar, if they push really fast, or yes, this is the disadvantage of the isokinetic. I understand exactly what you're saying, yes.
Yeah. I'm sure you know better on isokinetic. Okay, all right. Let me see. Is there any more questions? Okay, I think our time is up. So thank you very much, Kentaro-san.
ありがとうございました。
We hope to meet. We hope to meet soon. All right. And I gotta go to Japan because there's a lot of golf stuff over there.
For sure.
Yeah. Thank you. All right. Bye-bye. Okay. I think we have sat on our chair for quite some hours already. All right. So today we have a very interesting colleague and a friend of mine. He is Jerican Tan. Right, this gentleman here is a bodybuilder, and he does a lot of exercise, and he's good. And it's good that we have got him today to get us out from the chair, and let's do some X break. As a certified strength and conditioning specialist, a CSCS, and also a CPT, a certified personal trainer from the National Academy of Sports Medicine. He is also a certified personal trainer as well as a corrective exercise specialist. Also from the National Academy of Sports Medicine, he is a weight loss specialist and a fitness nutrition specialist, a certified PT from the ACE, American Council of Exercise, and also a group fitness instructor, also from the Council of Exercise. So I think we have 254 people online today with us. So let us all stand up and follow Jerican for an exercise session. You can take over now, Jerican. Nice to have you with us.
Thank you, Dr. Lee. Hi. Can you guys hear me? It's all good? Yeah, okay. So I thought you guys have been sitting all day long. Thought it would be a great idea if I can let you experience an exercise which can help you to improve your stability and mobility of your pelvic. That will definitely help in lower body movement. Is that okay? All right. So may I have I mean, I hope you guys are on a standing position. If you can turn on the video, that will really help me. If not, I'm not sure who's following me. Okay, so yeah, give you 10 seconds to get yourself into a nice standing position. I know you have been sitting. Hope you can see me from your camera. Okay, all right, so I recommend you to stand at a good standing position, feet at shoulder width apart. Can we stand at feet shoulder width apart? Okay, you're standing, yeah? So your feet slightly turn out. Is that okay? Feet slightly turn out. You only have 10 minutes to do this, right? And I'd like you to put your hands in front of you for a better balance. Bend your hip a little bit and your knee a little bit, just a little bit, just to cushion it, just to cushion your weight. Just a little bit. Although, as I said earlier, we are trying to practice a pelvic mobilization work. So what I want you to do is to now at this position is to round your back on your pelvic, all right, on your pelvic, not your upper back. Wait, we're gonna round and then we're gonna arch. Okay, all right. So you gotta follow my cues, yeah. Okay, so round and arch. Okay, round and arch. And I'd like you to adjust to the normal position. Okay, all right. So let's make your life a little bit difficult, Ken. So I want you to put your hands now on your thighs, next to your thigh. Is that okay? Next to your thigh, right? So now arch, arch. Yeah, so that means you are anteriorly tilting your pelvic, arch, and then you round. Okay, one more time. Let's arch. And let's round. Now put it back to the neutral position. Okay, so we're gonna make this a little bit more challenging. Is that okay? Put your hands on your knees. Okay, put the hand on your knees. So make sure that your shoulders are over your knees and over your midfoot. Okay, all right, and your weight should be equally distributed on your feet. Is that okay? All right, so now arch as much as possible, arch your pelvic as much as possible. And then we round. Okay, let's try it one more time. Let's arch as much as we can. And then we round. And we put your pelvic back into the normal position. Okay? All right, and from this, I would like you to stand up straight. Stand up straight. Yep. Okay, let's try one more time, okay? Down, hands on your knees. Come on, hands on your knees. Arch, round, arch, round, back to a neutral position. This time we are about to stand straight, about to. When I say stand straight, I want you to use your glutes to drive you up. Is that okay? 1, 2, up. Stand up. Yep, use your glutes to drive you up, okay? All right, so we're gonna make it a little bit more challenging, right? So right now, we're gonna go slightly lower, your hand next to your shin. Hand next to your shin. So we are slightly lower now, okay? All right, you ready? Now we're gonna arch as much as we can. When we do the arch, you probably feel the stretch of the abdominal, all right? And then when you round, you're gonna feel the stretch of your lower back, your erector spinae. And then we're gonna arch again. And then we're gonna round. We're gonna put you back to a neutral position. Just like drill, yeah? So we're gonna stand up. Remember the muscles that we're gonna use. It's a glute, yeah? We're gonna use the glute. And I count 3, 2, 1. You're gonna stand up. You're gonna fire your glutes and stand up straight, strong, okay? 3, 2, 1, drive up, strong. Good. All right, you're gonna try it one more time. You're better now. You're better now. I can see from the screen. Okay, let's hands at the side on your shin. Okay, and the side on your shin. Okay, let's arch. Remember, feel the stretch of the abdominal. Round. Okay, remember the movement comes from your pelvic, not your thoracic spine. Arch. Round. Arch. Round. Now back to your neutral position. Back to neutral position. Are you ready to stand up? At the count of 3, 2, 1, drive up using your glutes. Good. Okay. So last one, okay? Last one. We're gonna go even lower. Okay? So right now, your hands should be able to touch your feet. Whoa, this is difficult, okay? If you think you feel pain, you want to go slightly higher position. If you're not pain, you don't feel any pain, you follow what I do, okay? Hands next to your feet. You can touch your feet. Okay, we're gonna try, yeah? Arch, round, arch, round, arch. It's your pelvic, not your thoracic spine. Round, arch, round, arch, round, neutral, ready. Remember, you drive through your glutes, yeah? 3, 2, 1, drive up through your glutes. Okay, nice. Okay, last set. I promise you last set, okay? Last set. So let's go down to the lowest you can, okay? For me, hands next to my feet. If you can't, on your knees, or if not, just on your thigh. Okay? So from here, arch, round, arch, round, arch, round. Remember, moving through your pelvic. Arch, round, neutral, ready, 3, 2, 1, drive up using your glutes. Okay. Are you guys all right? I thought you've been sitting all day. Just thought that I could get you moving. It's a very simple exercise. Usually I recommend trainers to teach this to your clients. Why? Because pelvic mobilization will definitely help, okay, to improve their lower body movement like a squat. When someone performs a squat, it's very important that they have good awareness on their pelvic position as they're performing squats. Okay. That's the exercise for you today.
Thank you very much, Derek.
Right? 10 minutes.
Yeah.
Thank you.
Make sure you make yourself free next year. We're going to see more of you.
I hope to join you.
Okay, all right. Thank you.
Appreciate it. Thank you very much.
Thank you for joining. All right. Okay, now we are going to break to the rooms for the symposia on exercise and rehabilitation by Sufan, and then Professor Farkesh will be looking into exercise and injuries. All right, I'd like to do a short reminder that an e-certificate will be awarded to those who are in attendance of more than 20 hours over these 5 days. All right. The system of this seminar or webinar will record your attendance as you logged in. So once the system has captured your 20 hours and above, we shall issue your certificate. All right, have a good symposia. Thank you, Sufan. Thank you, Professor Farkesh, for chairing the session. Thank you very much. Please proceed.
Thank you, Dr. Lee. All right.
Pick up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspired Pick up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. Here is where we stand. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving.
Okay, welcome back to room 1. And I will chair this session. So good afternoon, everybody. Good morning, or wherever you are from. My first speaker is Professor Marco Pang, and he's going on live, okay? Professor Marco Pang is the professor of the Department of Rehab Sciences and director of University Research Facility in Behavioral and System Neuroscience at the Hong Kong Polytech University. And he is the editor-in-chief of Hong Kong Physiotherapy Journal, and he has written over 130, has published in 130 journals. He is also the associate editor of Physiotherapy Canada, and presently he is the president of the Hong Kong Physiotherapy Association. Now his talk will be on falls prevention after stroke. Welcome, Professor Marco Pang. The floor is yours.
Okay, thank you very much. Can you hear me?
Yeah, loud and clear.
So I'm going to share my PowerPoints. Can you all see my PowerPoints?
Yes.
Okay, very good. Okay.
Yeah. Okay, right.
Okay, fall prevention after stroke. I guess a lot of us know already that stroke patients are more likely to fall compared with the age-matched reference population. And you can see in this table here, it doesn't matter which stage of stroke recovery that you're looking at, acute, subacute, or chronic, the fall rate after stroke is higher compared with the reference population. And we all know some of these falls might lead to serious injuries or even death, as you can see the statistics here. When you look at the risk factors of falls after stroke, reduced balance is one of the major factors, and gait deficits is another. But when you look at the various risk factors of falls, it's really like multifactorial. There are other risk factors that have been studied, including depression, cognitive deficits, hemi-neglect, or self-care disability. So in our intervention, we want to target some of these major risk factors. And there was a Cochrane systematic review published in 2019 looking at the fall prevention strategies after stroke. Now, when you look at the overall evidence, these are some of the intervention strategies. So one particular study looked at the pre-discharge home visit, okay, and this is the result, no effect. Prescription of single lens vision glasses instead of bifocal glasses, no effect. Prescription of a servo-assistive walker, no effect. And one study examined the effect of transcranial direct current stimulation, TDCS. And this study had 60 subjects, so not a large sample size. And they found significant effect in reducing the number of fallers, and this is the odds ratio. But when you look at the quality of the study and everything, it is the strength of the evidence is relatively low quality. So I guess there's no conclusive evidence yet. Now, in physiotherapy, in conventional physiotherapy anyway, we want to, again, prevent falls in these patients as much as possible. And we want to target balance and gait deficits, as we mentioned. So in our physiotherapy training, we give resistance exercise training to improve the muscle strength, because muscle strength is very much related to balance ability. Of course, balance exercise training and gait retraining using various methods. Okay, so what is the evidence so far? In that same Cochrane systematic review and meta-analysis, I want to highlight two things. The conclusion, one of the conclusions is that it's still uncertain that exercise may reduce the rate of falls and number of fallers compared with control condition. So this is rather disappointing. And when they did subgroup analysis for people who have chronic stroke specifically, and the conclusion is that exercise resulted in little or no difference in the rate of fall. Okay, so we've been doing this for years, different types of exercise training, trying to reduce the fall rate or the number of fallers, but it seems like when you look at the overall literature, there's not much evidence out there supporting the use of this different exercise training in terms of reducing fall rate or the number of fallers. Okay, so this is rather disappointing. So what is the missing piece? And I thought the ability to engage in dual task while walking or while you're trying to balance yourself might be a missing piece in some of the conventional training methods. Dual tasking while walking refers to various daily living situations, such as engaging in a conversation while walking, attending to the different traffic signals while walking, and it's easy to think that dual task walking is essential in functional community ambulation. I just want to give you some background on dual task ability. This is one of the earlier studies that looked at dual task walking. They used what they call a stop walking when talking test. And they found 41% of stroke patients, when you're trying to initiate a conversation, when they're walking, they actually had to stop walking in order to initiate a conversation. So they cannot do two things simultaneously. And another study, they did the 5-meter walking test and they measured the walking performance and they impose a cognitive task, which is a shopping list recall task. And they found when you added the cognitive task, the stroke group had longer walking time and reduced number of items recalled compared with the age-matched population. In addition to that, they found during this dual task condition, a reduction in stride length could significantly differentiate followers from non-followers. So there are some implications here. So in my study, I wanted to assess the effects of a dual task balance and mobility training program. And the main outcomes are the degree of cognitive motor interference in walking. And of course, another major outcome is falls. And I studied the chronic stroke population. And this is a randomized control trial involving 3 treatment arms. These individuals, they came to our lab 3 times a week for 8 consecutive weeks. And we have 3 groups, and each group underwent different exercise training. The first group, they engaged in dual task mobility and balance training. The second group, single task balance and mobility training. And the third group is just a control group, an active control group who engaged in some flexibility exercises and upper limb exercise training. In terms of the assessment, we assess the outcomes at baseline within 1 week after the 8-week training period, and also 8 weeks after the end of the intervention period. And to measure falls, we follow these individuals for 6 months after the end of the training. And these are the selection criteria. We included chronic stroke individuals aged 50 years or above. They're all living in their own homes, and you can see some of the major criteria here. They have to be relatively cognitively intact, and they need to have some balance deficits, okay? But they should be able to walk for a short distance without manual assistance. It's okay if they use a walking aid, but they should not need physical assistance to walk a short distance, okay? So this is one of the criteria. So the dual task training group, okay, so they spent an hour with us, and 30 minutes, they engaged in some warm-up, flexibility exercises, and the 30 minutes is really about the dual task training. What does that really mean? Dual task training. Well, dual task meaning they need to do the motor task and the cognitive task simultaneously. Some of the motor tasks used included, the typical walking or balance exercises that we use in conventional training, using steppers, obstacle course, walking around tables, reaching, all these different balance and walking exercises that you have probably used before. During the 8-week training period, we try to increase the level of difficulty as able by reducing the base of support, because we want to challenge the balance a little bit more, increasing the speed of movement, and introducing inter-trial variability, walking on different surfaces, things like that. We combine that with various cognitive tasks. So there are several categories of cognitive activities. So when these subjects were walking through an obstacle course, we're asking these individuals to perform cognitive tasks as well, such as verbal fluency tasks, mental tracking tasks, working memory, discrimination, and decision-making tasks. Okay, so I'm going to show you a video so that you have a feel of what these subjects were going through. So, we have 2-stroke patients here doing this stepping exercises, sideways stepping in this case. And you can hear in the background every so often. Okay, so we were playing an audio tape. So every so often, I don't know whether you're able to hear it, but in the audio tape, we have different musical instruments. So every few seconds or so, then the patients would need to tell me, okay, what musical instrument is being played. So this is an auditory discrimination task, but at the same time, they need to maintain their balance while they were stepping onto the stool. Okay, so they were doing 2 things at the same time. And this is another task. So they need to walk along this horizontal ladder. They're not supposed to step onto the horizontal bars. So they need to avoid stepping onto the horizontal bars. But at the same time, we gave him a category naming task. And the category was randomly chosen, okay? And in this case, in this particular case, the patient was asked to name as many occupations as possible, like doctors, nurses, physiotherapists, and so on, okay? As fast as he can while maintaining his walking performance. Okay, so that's another exercise. So that's the dual task training. And single task training, we use exactly the same activities, but these tasks, the motor component and the cognitive component, they were done separately. So 30 minutes of balance and mobility exercises, no cognitive loading, and another 30 minutes in the sitting position, engaging in the same cognitive activities like you saw in the video. Okay, so these 2 components were done separately. And the control group, the active control group, some flexibility exercises and upper limb exercises, mainly for control purposes. In our assessment, we want to assess dual task performance. Okay, so not just your typical 10-meter walk or time up and go, but we introduced a cognitive component in our assessment. So we chose 2 cognitive tasks, verbal fluency and 0-3 subtractions, because these represent 2 different cognitive domains, and also the reliability and validity have already been established for these 2 assessments. And so with these assessments, so there are 4 combinations, as you can imagine, because we have 2 mobility tasks and 2 cognitive tasks. So they were done in different combinations. So in your assessment, you ask the subject, for example, to do the time up and go test while performing a verbal fluency task. And you measure the performance of the mobility task as well as the cognitive task. Okay. So walking time is one of the measures. How long does it take for the individual to complete the time up and go, for example, in single task condition and also in dual task condition. So basically, we're very interested in looking at the difference in these 2 conditions. Ideally, there should be minimal difference, right? Because if you introduce the cognitive task, okay, ideally, it should cause minimal impact on your walking performance. So this is what we would like to see. But as I said, a substantial proportion of stroke patients, when you introduce a cognitive task, they even stop walking. So that would really increase the time required to complete the time up and go test, correct? So this is what we are interested in, the walking time, the difference between the dual task and single task condition. But we also want to measure the cognitive performance, okay, the verbal fluency task or 0 subtraction task, how many correct answers they are able to give me during that time period. And again, we compare between the single task and dual task condition. Because ideally, again, the performance should be roughly similar between the single task and dual task condition. And as I said, we measure falls. Okay, so we have a fall diary and we give them monthly telephone calls. So these are the subject characteristics. Basically, there is no significant difference in terms of the key characteristics among the 3 groups, the dual task, single task, and control. And this is nice, okay, because we don't want to have very different characteristics before they even started the respective interventions. So these are the key results. When we looked at the dual task mobility, so this is the forward walking task. It's like your typical 10-meter walk test. And this is the outcome measure, the dual task effect in walking time. As I said, the purpose of the therapy, we want to reduce this number as much as possible. As I said, if there's absolutely no difference between the single task and dual task condition, then this number should be 0. Okay, so the black bars represent the baseline performance. So it's roughly 25%. So that means on average, in a dual task condition, the subjects took 20% more time to complete, let's say, the 10-meter walking test compared with the single task condition. So they slow down by like 25%. And we want to reduce this number by our therapeutic intervention. So here, after the intervention and also the follow-up assessment, and we found there was a significant reduction of this dual task effect after the dual task intervention. But this effect was not observed in the other 2 groups. Okay, so it doesn't matter whether you're combining forward walking with verbal fluency or forward walking with 0-3 subtractions, you see similar effects with our dual task training. So this is a more difficult task, time up and go combined with verbal fluency. And again, we saw significant treatment effect with the dual task group. And we saw a similar trend for time up and go and 0-3 subtractions, but statistically, it's not quite significant. It's pretty close. Okay, but you see the trend there. So that's the dual task effect on mobility. But as I said, we also measure dual task effect in cognitive performance, the correct response rate, CRR. Basically, it showed no significant change after treatment. And this is important because that means the improvement that we saw in dual task mobility is not accompanied by decline in dual task cognition. Okay, so what it really means is that it's a real improvement in dual task mobility rather than a mobility cognitive trade-off. Okay, so the patients did not sacrifice dual task cognitive performance, okay, by improving the dual task mobility performance. So this is not just a change in strategy, it's not a mobility cognitive trade-off, it's a real improvement in dual task mobility. In terms of the fall rate, we saw pretty good results. When we look at the number of fallers and the number of participants who sustained injuries because of the falls, we saw significant treatment effect with the dual task group compared with the control group. In the single task group, actually, you saw some effects, but mathematically, it's not quite significant, even though you see the trend there. So the dual task group, based on this analysis, is superior to the single task group in terms of reducing the fall rate, the number of fallers, I should say, and the number of people who sustain fall-related injuries. What about the number of falls? Because for some of the individuals, they sustain multiple falls. So in addition to measuring number of fallers, we also measure number of falls itself. And again, we saw a similar trend. The dual task training group, significant reduction of significant smaller number of falls, as well as the number of falls that cause injuries. So these are the numbers for the dual task group compared with the single task group and the control group. So again, the dual task group show better results. Okay, and what are the circumstances of these different falls? Actually, 1/3 of the falls occur outdoors, and the most common fall-related activities were, no surprise, weight shifting while standing. So this is related to standing balance as well as walking. And we also asked the patients, like, what is the perceived cause of falls? Actually, this is quite interesting. The most common perceived cause of falls was related to problems with divided attention. And this is exactly what happens with dual tasking. So it's not just walking. You are, in a way, distracting the patients by adding a cognitive task. Okay, so through our training program, we are training the patients to manage these different dual task conditions that require divided attention. So in conclusion, in community living people with chronic stroke, our 8-week dual task cognitive motor exercise program was more effective than the single task training program or the control intervention in improving various outcomes, including the dual task mobility function, reducing the fall rate, and fall-related injuries. And the paper was published in the journal Stroke. So if you want more details, you can refer to that. So I would like to acknowledge my funding source and my collaborators. These are some useful references if you want to study dual task function in stroke patients more. And that's the end of my presentation. Thank you.
Right. Thank you, Professor Marco Pang, for your very interesting research. And I'm sure there are many physiotherapists or people who are doing exercises or treating strokes. And I think this is a very good research that Professor Marco has done. And is there any question for Professor Marco? Okay, you can type in your questions in the Q&A session if you have any questions for Marco Pang. Anyway, if there is none, then I would like to ask Professor Marco Pang one question. Okay, I'm sure you carried out this research for your the place where you are working. So I would like to know that how successful is this for the hospital, and also what are the criteria for selecting your patients? Is every stroke patient suitable to come into your program?
Okay, we recruited patients from the community. So these clients were, had been discharged from the hospital already at the time of recruitment. In Hong Kong right now, we have a few NGOs who run community stroke rehab programs. They use my program as part of their routine rehab services for stroke patients. So this is pretty encouraging. In terms of selection criteria, these patients, as I said, they should be able to walk for a short distance without physical assistance. So if you have someone who needs physical assistance, then they may not be ready for this type of training, because as you can saw in the video, the exercises were actually quite challenging because they need to manage the walking task in addition to the cognitive task. Okay, so it's more for patients who are able to manage the independent walking function to a certain extent. And now we want to really prepare the clients for community living, because look, it's different from walking on a treadmill. Because when you're out there in the community, you need to manage, when you walk in a shopping mall, you need to pay attention to many different things. In the community, when you cross to the opposite side of the road, you need to attend to the traffic lights, people coming by. This is what we mean by divided attention. You need to manage many different things at the same time. It's not just making the steps. Okay, it's more than that. You are using, your motor system as well as your cognitive system all the time in community ambulation, which is a less protective environment. So we want to, well prepare our patients for community living. So this is why we, came up with this program. Rather than just telling patients to walk faster or trying to correct their gait, or of course, walking on a treadmill has other benefits like the cardiopulmonary and all that, but it's very different from real life walking.
Right. Thank you, Professor Marco. So we understand now why strokies are so scared to go out to the shopping mall and all this, because they just cannot manage doing too many things at the same time, So I understand perfectly now your research is about getting people to interact with their environment when they are out in the open with the public. And right. Thank you very, very much for your very informative talk. And we hope to see you again.
Yeah. Thank you very much.
Thank you
for your invitation. Yeah.
Thank you.
Yeah. Bye-bye.
Bye. Okay, we will move on to the next topic. And the next one, the speaker will be Professor Prof. Yuling Wang, and he is from China. He is the professor and head of Rehabilitation Medicine Center in the 6th affiliated hospital of Sun Yat-sen University. He is also the president of Chinese Physical Therapy, and he has the National Natural Science Foundation of China Fund, Chinese Medical Board grant, and international grant several times. Congratulations, okay? And he is also the editor and reviewers of a scientific model. And our Professor Yuling's talk will be on exercise to enhance recovery after surgery. Welcome, Professor Dr. Yuling Wang. The floor is yours.
Good afternoon, everyone. This is Dr. Yuling Wang. I come from China. I worked in the 6th affiliate hospital of Sun Yat-sen University. Currently, I'm head of a Rehabilitation Medical Center. It's my honor to join the WCM again. This is my 3rd year in WCM. Thanks Dr. Sufin's kind invitation. Thanks the invitation come from the conference. Today I want to share with you a topic on exercise to enhance recovery after surgery. When we studied our ERAS work, we worked together firstly with the intensive care unit. We met the head of the department. We worked together with the team. We also discussed any questions with the physicians in the ICU, and also worked together with the nurses team. And we shared the knowledge. We discussed together in the whole team. Okay, let's move to the ERAS concept. Everybody to know the ERAS concept is come from the first definition or first conception come from Dr. Henrik in Denmark. We elaborate ERAS in short for enhanced recovery after surgery. The ERAS definition refers to a multimodal preoperative care pathway or protocol designed to achieve early recovery for patients undergoing major surgery. So that's it. Say ERAS is patient-centered, a multimodal, multidisciplinary. It's also evidence-based practice or evidence-based make decision. The ERAS teamwork and everyone in the team works towards the same ultimate goal to achieve faster patients recover and fewer complications after major surgery. We all can confirm the ERAS pathways have been implemented successfully in many other disciplines, including orthopedics, neurological surgery, gastroenterology, cardiovascular, pediatric surgery. In our hospital, we have a big record. That means in the same hospital, we conducted more than 5,000 operations on colorectal cancer. That's the biggest number throughout the world. So our team also worked together with surgeons in gastroenterology. And there are many key components of ERAS. We're talking about the key components include three parts. The first part is preoperative, second is intraoperative, and the most important thing is the postoperative rehabilitation or physical therapy intervention. The preoperative, we will educate the patients, we communicate with the patients how to conduct the pre-exercise, how to pre-warming, how to recognize the key important role of respiratory management after the operation. And after the post-operative, the most important thing for physiotherapists is the exercising. We educate, we promote or encourage the patients to conduct the early mobilization, early exercising, so they can reduce the complications. They can also help them to improve the quality of life. This means when we conduct the enhanced recovery, that means ERAS, they can lead to a significant improve the patient satisfaction, because after the operation, more and more people, professionals can care about them, especially for physiotherapists can help them on the early sitting or early standing. and also that leads to the outcomes and the reductions in cost of care. And specifically, patients experienced a fast recovery, shortened hospital stay, and significantly fewer complications. So what's the exercise role? If we talk about exercise is medicine, the exercise role in the ERAS, when we finished the many patients in ERAS section, we found the exercise is, can be more benefits. Like generally, the exercise role can help to maintain a healthy body weight, lower blood pressure, decrease the risk heart disease, and other benefits. But in the cancer survivors, all we said how to conduct exercise in ERAS or after ERAS. The exercise intervention among the cancer survivors can improve the quality of life and improving the physical functioning. And many reviews and other studies also improved the anthropometrics measures. It also can improve the status of health-related biomarkers and increase the engagement in social activities, can encourage the patients or the cancer survivor to return to family or return to the society earlier, and also can lessen the sleep disturbance. And there also have many adverse effects of cancer treatment. That's why we want to reduce the adverse effects. We list the adverse effects like the anxiety, the bone health, cardiotoxicity, cognitive function decreased, falls, depression, or fatigue. And also talk about the adverse effects on the health-related quality of life, lymphedema, nausea, pain, physical function, even the sexual function. That's the adverse effects of cancer treatment. So how can we help them in different way, different direction? Now we are talking about how to improve them, how to help them. That key important thing is exercising has a role across the entire cancer continuum. They say by Dr. Carey is one of the authors of new guidelines, the exercise guidelines for cancer survivors, the consensus statement from International Multidisciplinary Roundtable, and the comprehensive review supporting it. She said, we now have an obligation to start moving exercise into the standard of care for cancer patients. And we also know the benefits of the exercise come from this great study. They said the physical activity can reduce the risk of recurrence and mortality in cancer, can indirect the effects related to the host tumor microenvironment. That's very good, exciting news. It also can produce the direct effects on cancer cells. One of another studies confirms 16 weeks supervised aerobic and resistance exercise intervention appeared to reduce the Framingham risk score and predict the 10 years risk of cardiovascular disease in women with early stage breast cancer, with overweight conditions or obesity. And this study published in JAMA Oncology. Another paper published in the PLOS Medicine confirmed the community-based football in men with prostate cancer, 1 year follow-up on a pragmatic multicenter randomized control trial confirms in this trial that said the participants are located to the football appeared to have improved the hip bone density and fewer hospital admission. This in positive results. Another study also showed effects of the exercise and nutrition pre-rehabilitation on functional capacity in esophagogastric cancer surgery. That's published in JAMA Surgery. The conclusions and relevance talk about pre-rehabilitation improves the preoperative functional capacity in ES surgery, keeping the patients from the physical and nutritional status decline could have significant effects on the cancer care continuum. Let's move to the application of rehabilitation in ERAS, especially for the role of the rehabilitation in the ERAS. During the ERAS, the procedures, not only the exercise or early mobilization, we also consider about how to assessment, to chest hygiene, the cardiopulmonary trainings, the pain reductions, and the physical fitness, and how to return to home and society. There are many risk management of ERAS, pre, post, and post-discharge. We encourage them to do more exercise to reduce the length of stay in hospital and to reduce the post-treatment complications, enhance the recovery following treatment, enhance the quality of life, and try to improve the cardiorespiratory fitness, nutrition, and neurocognitive function. During the pre-rehabilitation exercise, we encourage the patients to do some cycling exercise or the tailored Tai Chi or others, the traditional Chinese exercise, to conduct this aerobic exercise to improve their cardiopulmonary function, and also encourage them to do some resistance exercise like these different styles, and also encourage them to do, especially for the patients they should do in the section after the post-operations. So the shoulder abductions, elbows, the upper limbs exercising, the lower limbs exercising, they are all fit for them. And pre-rehabilitation breathing exercise is most important for the thoracic breathing, diaphragmatic breathing, or force expansion techniques, or coughing techniques. That's a key event for them in the breathing exercise. Then post-operative evaluations, we conducted the cardiopulmonary function assessment, like when the patient have gastrointestinal function problems. We also conduct this assessment, the risk assessment and of the thrombosis, and pain assessment, risk estimate, pipeline safety. After the operations, the early mobilization, also the early exercising, we record this video by the sample and show them to the patients in their mobile phone, or showing the screen in the wall, and to encourage them to conduct this very important early mobilizations active work. And we also using the motormate, the bike training in early mobilization section. And we also encourage every patients, if they can do, to early sitting and early standing or early walking. After the exercising section, we also using another different kind of rehabilitation interventions like TENS or electrical stimulation in different part of the limbs or trunk then if they need. And acupuncture is a very popular intervention in our country. But another side, if we talk about exercising the ERAS, the traditional Chinese exercise, we encourage every patient, if they like it, we use the tailored Tai Chi, just like select the different style of the Tai Chi to encourage them to do more exercising and of Tai Chi or Ba Duan Jing, other traditional Chinese medical exercising. This is the study they reviewed the Tai Chi for cancer survivor. In this medical review, they say the evidence emerged to support the benefits of 40 to 60 minutes of the supervised Tai Chi for 8 to 12 weeks can improve the fatigue and sleep quality in cancer survivors. We also conduct the electroacupuncture, try to reduce the duration of post-operative lives after the laparoscopic surgery for colorectal cancer. That's an interesting study. And the pulmonary Daoyin is one of the Qigong, as a traditional Chinese medicine rehabilitation program for the patients, to encourage them, the IPF patients, to do more exercising. So the conclusions indicated the clinical meaningful difference in 60-minute walk for these PD programs. And that's we talk about the exercising interventions in ERAS section. Actually, ERAS is conducted by the multidisciplinary team. The team members come from the ICU, the surgeons, the nurses, nutritionists, and the rehabilitation team, especially for physiotherapists. So that's key. Also, the power and weapon come from the physiotherapist. So our conclusion talk about the ERAS in the program maybe can help by the exercising. So the early mobilization, the physical activities is encouraged by the physiotherapist to conduct it after and pre-operations function recovery. And exercising training is generally safe in ERAS section, so we can do that if you can. If you want to try to help the patient after the surgery. Okay, that's my sharing in this section. Thanks for the kind invitation. Again, thank you for the listening. Any discussion, any comments? Thanks.
I'm sure ERAS is practiced in many countries throughout the world, because I know Malaysia too is practicing ERAS. Okay, so it is actually very good to share with us this topic. And yeah, you have one question, and it is from Dr. Zubair Qureshi. And he would like to know what type of exercise should we perform on cancer patient.
Thanks. It's a very interesting question. Actually, I elaborated already in my presentation, talking about how to conduct the exercising in ERAS section or the cancer survivors. Actually, we need to discuss with the physician. Also, we need to know the history of the patients. After that, we can conduct the assessment and evaluation. We can conduct the resistance training or aerobic training or some agility training if they need it. Okay, but it depends on the conditions or status, like the acute or subacute stage. We just encourage them to do some lower intensity exercising. And after that, if they can recover better, and then we can encourage them to do more intensive exercise. Some cancer survivors, they can go back to the very normal exercise. So that's why we have to conduct the exercising to encourage them to return to the normal activity, living, or return to the society. Thanks. That's a very good question.
All right, thank you for the answer. If you have more questions that you would like to ask Professor Yuling, you can always contact him. And let's welcome him again, I hope, because he has been with us for the third time, okay? So thank you again very much, Professor Yuling Wang, for your very interesting talk. Thank you.
Thank you, Dr. Thanks. Bye.
Bye-bye. Okay, we will move on to the next speaker. And he is none other than Dr. Karma. Oh, I have problem pronouncing his name. Dr. Karma Pugh. Will you help me?
Finso, that's fine. Finso.
Finso, okay. He is from Bhutan. And you know where Bhutan is? Bhutan, I'm sure, is a very beautiful country. Okay, this is where everything is green, right? Okay, so Dr. Karma is a physiotherapist, and he is also the clinical manager and senior clinical leader for Inpatient Physiotherapy Center, Jigme Dorji Wangchuk National Referral Hospital, long name. And he is also the lecturer with the Department of Physiotherapy, Kesa Daipo University of Medical Sciences, Bhutan. So without wasting time, let us welcome Dr. Karma. The floor is yours.
Hello, greetings from Bhutan to all the participants of the 5th World Conference on Exercise Medicine. My name is Karma Finso. I am a physiotherapist working in one of the national referral hospitals in Bhutan. It's a great privilege for me to have given such opportunity to share our experiences in the field of exercises and rehabilitation. I'd like to congratulate all the organizers for making this event possible through a virtual platform. And I'd like to thank Sufen Yu, the chair of the symposium, for giving me this opportunity. Thank you very much. This is the content of my presentation. I'll be briefly talking about the healthcare delivery system in Bhutan and physiotherapy and rehabilitation services which are part of the healthcare delivery system under the Ministry of Health, and some of the key challenges that physiotherapy and rehabilitation services face, and number of opportunities that are there for exercise and rehabilitation to be incorporated in the healthcare delivery system. As most of you may or may not know, Bhutan is a very small country and it is situated in the Himalayas. It is a landlocked country between India and China. Bhutan has just under 1 million population and just over 36,000 square kilometer. The development philosophy of Bhutan is gross national happiness, and the healthcare is provided free of cost by the state. The provision of free healthcare services also include physiotherapy and rehabilitation services. However, there are a number of resource inequity when it comes to providing physiotherapy and rehabilitation services. Gross national happiness is the development philosophy of Bhutan. Country's progress is measured by the GNH index. There are 9 domains and 32 indicators. In the 9 domains, health and psychology well-being are the 2 domains that is relevant to health and happiness. So the state must provide conducive environment to pursue good health and sound mind. So these slides will briefly talk about the healthcare delivery system in Bhutan. Bhutan has achieved more than 95% of primary healthcare coverage, and the public health system in Bhutan is quite robust, and because of this, Bhutan has been able to combat the COVID-19 pandemic. So in the community and the primary level, we have basic health units or the primary healthcare centers that provide access to healthcare services in the communities and in the remote parts of the country. And the next level is the secondary level, wherein we have hospitals. We have 48 hospitals in the secondary level. At the tertiary level care, we have regional and national referral hospitals where all the tertiary care are provided. So the pathway for the patient to access healthcare services is from the primary to the secondary to the tertiary level. As I said already, the healthcare services in Bhutan is provided free of cost by the state, and it is enshrined in the Constitution of the Kingdom of Bhutan. That's why, to this end, the government spends 3 to 6% of its annual GDP to health. Ministry of Health under the government of Bhutan is the central authority for provision of healthcare services in the country. This also include physiotherapy and rehabilitation services. Physiotherapy is and remains a phase of rehabilitation service in the country. Rehabilitation is principally provided through physiotherapy services. Physiotherapy services are available in the majority of district and regional referral hospitals. Physiotherapy department at the National Referral Hospital is one of the clinical departments and has a number of inpatient and outpatient services. In addition, there are also some other rehab services such as audiology and speech therapy, prosthetics and orthotics, and occupational therapy services. Exercises and rehabilitation, physiotherapy and rehabilitation face many challenges. I'll briefly talk about these challenges under these 3 broad categories: accessibility, constraint of resources, quality and competency issues. One of the key challenges for physiotherapy and rehabilitation service is excess of service by the people. Physiotherapy and rehabilitation services are not available in the primary healthcare centers and in the communities. Therefore, people in the remote communities cannot access physiotherapy and rehabilitation services. Out of 48 hospitals in the country, physiotherapy is available only in the 26 hospitals. And in the hospitals, at the national referral and also in the district hospitals, physiotherapy and rehabilitation do not have designated beds. So which means these professionals cannot keep the patients admitted in the hospital for the purpose of physiotherapy and rehabilitation. And most often than not, patients who are enrolled for physiotherapy and rehabilitation programs are often discharged prematurely, and the professionals are not consulted in the discharge process. After the patients are discharged, the problem of follow-up is also there. The patients who are discharged from the hospitals cannot come up for follow-up again owing to the access issues. Another component of inaccessibility is lack of awareness among the public and also among the healthcare professionals. Human resource is one of the biggest constraints faced by physiotherapy and rehabilitation services. There are only 34 physiotherapists in the country, and there are 68 physiotherapy technicians that assist or that provide extension service to the people. There are only 1.4 physio professionals per 10,000 population as compared to 5.6 doctors and 18.4 nurses per 10,000 population. The graph on the right shows that before 2005, the number of physiotherapists and physiotherapy professionals recruited by the Ministry of Health was very low. The reason could be because the supply of these professionals were not there during that time. So after 2016, the number of recruitment of these professionals have gradually gone up. However, although physiotherapists are considered exercise specialists, there are no physiotherapists who are specialized in different clinical discipline. Although physiotherapists work in different clinical settings in the hospitals, and by virtue that the National Referral Hospital has the biggest caseload, the number of physio professionals employed in this hospital is one of the highest in the country. The another concern regards to human resource is the increasing attrition rate among physiotherapy professionals. Although the healthcare services, as I mentioned, is provided free of cost by the state to the public, a lot of resources go into it. And again, although physiotherapy and rehabilitation services are very much part of the healthcare delivery system in the country under the Ministry of Health, the resources allocation to physiotherapy and rehabilitation is very minimum. In fact, this table shows no mention of health expenditure on physiotherapy and rehabilitation services. The expenditure on physiotherapy and rehabilitation services are all clubbed under one umbrella, that is either curative or preventive services. Other major resource constraints are physical infrastructure and equipment. Physical infrastructure is important for physiotherapy and rehabilitation services, especially in terms of space. Most district hospitals do not have adequate physical infrastructure in space to provide physiotherapy and rehabilitation services. The country also do not have a separate national rehabilitation center. It was planned and is still in the planning process. That may or may not happen. So in that way, the physiotherapy department and units in different hospitals have become the space and avenues to providing rehabilitation services. However, this is severely hampered by lack of adequate space, and also in the acute settings such as in the critical care, in the intensive care units, and in the wards. Most often and most hospitals have very inadequate space to work with patients by the physiotherapy and rehab professionals. And also equipment. Many physiotherapists working in different hospitals feel that they do not have adequate number or an appropriate equipment to work with the patients. Quality services provided by competent healthcare professional is very much part of the healthcare delivery system in Bhutan. There is a system in place to ensure that safe and quality services are provided to the public. Having said this, physiotherapy and rehabilitation professionals face a number of challenges in this respect. There are very few rehab professionals, including physiotherapists, posted in the district hospital, whereas many of them are confined to the national and regional referral hospitals. That way, quality of services is not ensured in the district hospital for the lack of qualified healthcare professionals in the district hospitals. Another challenge that this group of professionals face is dearth of research in the region, increased evidence practice gap, and most often the evidences are quite conflicting and confusing to this group of professionals in the field. Physiotherapy and rehab professionals also have very limited opportunities to higher education. Like I said, there are no specialist physiotherapists or no specialist other rehab professionals. So the educational opportunity provided to this group of professionals is very limited. And the another quality issue is in the practice of physiotherapy, exercise therapy and rehabilitation, there is a dominance and a generous use of electrotherapy and physical modalities. In fact, in many outpatient physiotherapy clinics, we can see patients flock to get electrotherapy procedures. So there is also lack of awareness and evidence practice gap in using electrotherapy and physical modalities. Another constant challenge faced by physiotherapy and rehabilitation professionals are the misconceptions. The misconceptions that affect quality of care. There is misconceptions among the public and also heavily among the healthcare professionals. They often think that the exercises are painful and damaging to the body, and the public do not opt or do not consult physiotherapists with respect to exercises, and other healthcare professionals also do not encourage other patients to do any kind of exercises or do not refer the patients for that matter to the qualified physiotherapists to get the opinion. The public and also the other healthcare professionals think that exercise is something that is very heavy and vigorous, such as heavy lifting, doing a gym, jumping, and all those sort of misconception that exercise means those heavy thing and that the patient cannot perform it, that the all people cannot perform the exercises, that the sick person should not do these exercises. All sort of misconceptions are there, and it is quite challenging for physiotherapists and other rehab professionals to implement or to provide quality of care to this group of population. And physiotherapists misconception is that physiotherapist is similar to what a masseurs do. So physiotherapy is all about massaging the body, massaging the tissues. All this kind of misconceptions dearly affect the quality of services here in our setting. So amidst all the misconceptions and challenges that the physiotherapy and rehabilitation service face, there are also increasing opportunities in this field. Exercise medicine and rehabilitation are becoming more relevant. There is increasing demand for better health and well-being against the rising cases of non-communicable diseases in the country. So thereby the demand for physiotherapy and rehabilitation services are also going to increase. We all know that physiotherapy and rehabilitation services are cost effective as compared to surgeries, compared to prolonged inpatient stay, compared to prolonged ICU stay. The investment in physiotherapy, exercise medicine and rehabilitation will definitely prevent these complications. There are opportunities and growing evidence best practices happening in the country among these professionals as well, and there is opportunity to strengthen physiotherapy services in the primary healthcare services and centers, whereby the services are made available and accessible to people living in the community and in the remote parts of the country. There are also opportunities for advancing educational qualification, clinical specialization and continuous professional development programs in this field. In conclusion, Bhutan has a unique and strong public health developed against the framework of the three-tier public healthcare delivery system. Physiotherapy and rehabilitation services are part of this framework and only need strengthening. Proper planning of human resources, infrastructure and policy framework will incorporate physiotherapy services and make the services available in the remote communities as well. So thank you very much. These are my references, and if you have any comments, questions and would like to contact me for certain clarification, you may write to me at the following address. Thank you and have a beautiful time. Thank you.
All right. Thank you, Karma. All right. Maybe some of us would like to visit you in Bhutan because we have heard so much about Bhutan. All right.
Sure, you're welcome.
Yeah, let's look at the question. There is no open question for you, but I would like to ask you one question. It's about the challenges that you faced in your country. And I was surprised to hear that the doctors are not referring cases for physiotherapy as they should. And this is quite a challenging job for you. So how do you plan to overcome these challenges that you face as a physiotherapist in your country with about 1 million population?
Thank you, Sue. Once again, thank you very much for the opportunity. When I actually also looked at my presentation as I listened, can you hear me, Sue?
Yeah, I can hear you.
Yeah, because I think there is some lag. So
yeah.
anyway, thank you once again. As I was saying, when I was also looking at my presentation, recorded presentation, a lot of challenges and negativities had been presented. But I think, exercises and rehabilitation, and as a healthcare professional, you can only do so much if there is a strong framework and support in the system itself. And pertaining to the question that you asked, it's the lack of awareness and also the misconception that I had talked in my presentation, that the physicians and surgeons, they do not have the awareness of the exercises and rehabilitation that would help the patient. So most often, patients coming to us, they self-refer, and then they are seen by our colleagues in different clinics in the hospital, of course. So that is the part of the challenges and the misconception. Having said that, there is growing culture of research and evidence among the clinicians, including physicians, surgeons, and also among the physiotherapy and rehab professionals. So that way, the awareness is increasing. And then because we are all part of the university, same university, we are also providing lectures to the residency program, postgraduate medical education residency programs, as and when they invite us to present the guest lecture. So that is really helping. And in general, there is the recognition by the Minister of Health and the government to have us in the team to, when they are looking at the systems development. In fact, currently what's happening is the Minister of Health is reviewing their service and human resource standards in the country. And for that, we have been thoroughly consulted. Thereby, we were able to give our inputs in the whole system development. Thank you.
All right. Thank you for your answer. I hope you success in. I wish you success in your facing your challenges, and that you will bring up your exercises and rehabilitation and make the doctors more aware of what you are doing in your country. Okay. So thank you very much for giving us this talk. Thank you.
Thank you. So thank you.
All right, we have the last speaker now, and she is Dr. Stacy from Trinidad. She has to wake up very early. I think now is 5 a.m. in Trinidad. Okay, so welcome, Dr. Stacy. She is the Executive Board Member, North America Caribbean Region, World Physiotherapy. She is also the Chair of Membership Committee, World Physiotherapy from 2020 to 2021. And she is also the member of International Scientific Committee, World Physiotherapy Congress, Cape Town, South Africa 2017. Yeah, I saw you in Africa, South Africa. And also she is a PW, Parkinson, right? Most certified therapist, okay? So welcome and thank you for waking up at 5 a.m. in the morning to be here with us. Thank you very much.
Thank you so much. I haven't regretted it at all.
Yeah, welcome to WCEM. The floor is yours.
Thank you.
Hello, everyone. I am Stacey.
We'll be playing our recorded version. So thank you for the host for playing it. And I'll be here for any questions after. Thank you all.
Hello, everyone. I am Stacey DeGale, physiotherapist from Trinidad and Tobago and Executive Board Member of World Physiotherapy. Thank you so much to the Scientific Committee for this, the 5th World Conference on Exercise Medicine, and for this invitation to participate in a congress of such caliber. Discussing weight stigma in physiotherapy is important as one, greater than 40% of the world's population is overweight, and two, I am a clinician who falls within that 40%. Allow me a few moments to become a bit philosophical with this presentation. A number of years ago, I was participating in an intermediate Pilates course for physiotherapists. The instructor asked me to be a model for the course, as they knew I was also a Pilates practitioner. As I walked to the front of the class, I heard a fellow colleague whisper, "How is she going to be our model? She's too fat to do this." As I looked up, I noted one or two other faces with expressions that agreed with her comment. After I completed every move with perfection, the look of disbelief on some faces was actually quite satisfying. But what was of concern was the realization that if these were the reactions of colleague to colleague, what then is our reaction to our patients? It is imperative, therefore, that we appreciate the meaning of weight stigma, because many of our patients may be victims of it. Weight stigma can be defined as negative attitudes towards persons who are overweight or obese, and this group is often seen as lazy, greedy, sloppy, less intelligent, and also unattractive. This can manifest as stereotypes, rejections, prejudice, and discrimination. Weight stigma has pervaded almost every domain in life, such as interpersonal relationships, education, employment, housing, and healthcare. So how and why, then, should we discuss this issue? How does weight stigma affect the practice of physiotherapists? Healthcare environments should typically be safe zones or safe spaces. Yet, weight stigma has inserted itself even within our profession. A profession where approximately 81% of physiotherapists believe that weight management is within our scope of practice. We should therefore be aware of weight stigma and its negative impact, and also to discuss the strategies that we must employ to address the issue. Physical and mental health issues. Weight stigma is closely related to physical and mental health issues such as depression, anxiety, even suicidal thoughts. There is also a direct increase of risk of development of chronic illnesses of which we treat. So, weight stigma must be paramount in our minds, because if we exude weight stigma, we are actually increasing some of the issues that we ourselves are trying to prevent. Cardiometabolic issues. Disease and mortality risks increase as a result of weight stigma. Higher levels of cortisol have been recorded, which can contribute to mortality risk by triggering eating and accumulation of visceral fat. There's also greater oxidative stresses on the body, and blood pressure has also been noted to increase. There are higher levels of pro-inflammatory cytokines such as C-reactive protein as a direct result of weight stigma. Maladaptive responses. Eating disorders and poor dietary choices are often prevalent in persons who experience weight stigma, and this is directly related to possible weight gain. Because of the perception that an individual's weight, shape, size may be a source of embarrassment, persons may avoid seeking much needed healthcare. Because of a level of distrust, a patient may not adhere to treatment protocols or follow advice of the healthcare professionals. Can you imagine all of these detrimental results of something as quote unquote mundane as weight stigma? It is not as simple as we may have thought, and we must give it further thought if we are to address the ailments, the illnesses, the diseases that we are presented with from our patients. This infographic, courtesy the World Obesity Federation, gives a lovely snapshot of weight stigma, including its perpetrators, causes, affects, effects, and some examples of how we, the perpetrators, can manifest weight stigma. So let's imagine our perpetrator in this scenario is a physiotherapist who, because of a lack of education or awareness of weight stigma, rolls their eyes repeatedly while speaking with an overweight patient who states it's difficult to exercise due to work-life issues. Our physiotherapist is unaware of their physical and visible responses to the patient and continues then to berate the patient for not exercising regularly. Our patient then feels embarrassed, goes on a crash diet, and does not return to the physiotherapist for much needed care. How could this scenario have played out differently if there was a level of weight stigma sensitivity by the physiotherapist? Perhaps the therapist can listen with gentle nods while the patient speaks, develop goals with the patient, develop a plan with the patient that is practical, so that the patient would then feel empowered with an improved sense of self, and therefore a higher likelihood of returning for further care. Let's discuss weight stigma on healthcare provider behavior. None of us deliberately discriminate against any of our patients for any reason. However, some of our behaviors may stem from negative attitudes about a stigmatized group, and this is called enacted stigma. This can decrease access of healthcare services and reduce a patient's compliance. Enacted stigma attitudes can be explicit or they can be implicit. Explicit attitudes are usually conscious and displays someone's opinions or beliefs about a group. This tends to predict our non-verbal communication, our eye rolls, our shoulder shrugs, our sighs. Implicit attitudes tend to be automatic, and persons are quite unaware that they're showing any negative attitudes to a person or a group, and it affects verbal behavior. Experiences of discrimination associated with weight stigma can cause patients to distrust and anticipate negative reactions in future healthcare encounters. These patients' reactions to being stigmatized can overlap in three processes: identity threat, stereotype threat, and felt stigma. Identity threat refers to where patients feel devalued and they lose their sense of self. And this is because of their past experiences. Stereotype threat. This is where the patient is aware that they may be seen as a member of a stigmatized group and is therefore so preoccupied in trying to detect stereotyping attitudes or behavior from the provider, it detracts from the care that they are receiving. Felt stigma. Here, the patient expects poor treatment based on their past experiences. Any patient who experiences identity or stereotype threats and felt stigma have higher levels of stress, leading to heart disease, stroke, depression, anxiety. They also avoid clinical care and may therefore present for care when their medical issues are much more advanced and so more difficult to manage. There is ultimately a lower value placed on their own health. We often feel that we are above it all as a profession. But in a study published in 2014, we are shown that, as with other health professionals, physiotherapists do demonstrate some level of explicit stigma. This research paper, which all of us should read, begins a much needed conversation about weight stigma in our profession, including our approach to the discussion surrounding body weight and the research that is still needed in the area. To deal with any problem, we must first acknowledge that there is a problem. The evidence shows clearly the negativity to mind and body where weight stigma is concerned. And as physiotherapists, we must face our responses to our clients because we live in a world where 40% of potential clients will be overweight. And most of us do acknowledge that weight management is part of our scope of practice as exercise experts. It is therefore time then to focus on health rather than on weight. Let our practices encourage healthy behaviors and use collaborative approaches with the patient in relation to their healthcare, as opposed to a teacher-student dynamic. Let us focus on what a person living with obesity can do versus what they cannot, versus what they look like. Let us move beyond just ideals on body mass index and waist circumference and look at the functionality of the body and encourage improved movement and healthy lifestyle choices. Our practices should provide levels of positive support. Even in our marketing and social media material, let us include diversity of size, shape, race, ethnicity, gender. We must take a weight-inclusive approach in public health training. As physiotherapists, we can be advocates and confront weight stigma in all areas of health. As researchers, we can encourage more scientific inquiry into this area. To avoid harm to the psyche and the body of our patients, we must consider the risk of contributing to stigma before beginning any intervention or initiative. Let us be mindful of our words and use of imagery. As simple as providing appropriate seating in our clinics is a means of avoiding harm. I've been to many clinics where there are chairs that are made for persons half my size, and sometimes I have to stand. Management of persons living with obesity should be part of physical therapy education. The complexities of obesity are not taught in most educational programs, and this, therefore, can increase episodes of weight stigma and, as a result, have deleterious effects on the mind and body of our patients. We have discussed already the effect of weight stigma on the body, on the mind, the depression, the anxiety, the maladaptive responses. So that if we want to be well equipped to manage these areas, to manage chronic disease, we must have a working knowledge as to the complexities of obesity, the strategies to overcome obesity, and to ensure that we minimize weight stigma. Weight stigma is experienced by persons living with obesity across many domains. And though we desire the best for our patients, we must be aware of our personal and professional bias. The extent of weight stigma and its detrimental effects forced the World Health Organization to make a formal call for the end of discrimination in healthcare settings, with specific attention to weight stigma in a statement made in 2017. As a profession, we must perform some introspection and address gaps in research, discuss strategies in mitigating against weight stigma, and ensuring our physical therapists are equipped to effectively manage this population. I love this quotation by Linda Bacon. Blaming fatness for heart disease is a lot like blaming yellow teeth for lung cancer, rather than considering the possibility that smoking might play a role in both. And telling people they need to lose weight is a lot like telling someone with pneumonia to stop coughing so much. It may not be possible and won't make the disease go away. It is time then for us to refocus our attentions from size and weight to health, wellness, movement, functioning of the body, and to ensure that we use positive words and positive imagery, because our words and our images are more powerful than we think. I would like to thank the scores of researchers who continue to do research in a not often spoken about topic. To all those who have continued to look at weight stigma, particularly in healthcare, this presentation would not have been possible. And a special thank you to our physiotherapists such as Jenny Setchell, who have continued to ask the tough questions, and hopefully we can continue answering them through critical research into weight stigma. Thank you again for this invitation and for allowing me the opportunity to be part of this Congress and to take, albeit a philosophical look and approach to weight stigma in physiotherapy.
All right, thank you, Dr. Stacy, for your talk. Very interesting graphics, but sad to say that it is a little bit small for most of us to see. Yeah, but very, very interesting. And point taken, we will not ask a patient with pneumonia to stop coughing. Something very interesting I heard today. And you know, one of our main objective of WCEM is actually NCD. And we know that population, yeah, many of us are getting more obese. Now with COVID and lockdown, many of us cannot go out to work and we are getting fatter, right? So let us all be sensitive, yeah, to patients who come to us and they are a bit obese or overweight. Do not whisper, do not make them feel that they are not welcome, right? I see here, all right, there is no question for you, but I would like to ask you a question. All right, what is the greatest paradox in consideration of weight stigma?
You actually started to answer that question, Sue, with regards to the fact that because of the increasing prevalence of NCDs, the increasing size of our populations, it is of grave concern. We should be concerned about it. But the irony is that over the last 8 to 10 years, there has been an upsurge in education about the value of exercise, the value of weight loss.
But at the same time, there has also been a doubling of the size of the population. So it is for us to wonder now, why are these strategies not working? And I think that one of the main reasons for that is the continual use of derogatory images, derogatory terms. For example, there's a particular type of exercise equipment being pushed now. I won't call its name, and only very slender persons are using the equipment to exercise. So what does that mean? I can't exercise on it. What encouragement are we giving this population to get healthy, to become not necessarily skinny, but to be healthy, to encourage them to use their bodies, to encourage movement? And it is really the greatest paradox. And I'm so happy that despite the small size of the presentation, thankfully, you all as hosts have sent a link so that it is there for all the participants to download, that we could really have a greater understanding of our implicit and explicit bias, and to try to help this population a bit more just by changing our language, by changing our imagery, and by being more supportive and engaging this population in their healthcare, not just giving instructions, but rather engaging them in making healthy and wiser decisions.
All right, thank you very much. And thank you, Stacey, for getting up so early in the morning to be with us. Thank you very much. Continue on to the next session. Okay, now we have actually come to the last part of the World Conference on Exercise Medicine. That is the presentation by many of our participants who have attended this session. And our first speaker is Professor Sivakumar on. All right, the speaker is Professor Dr. Sivakumar from India. And his topic is effects of Mulligan mobilization with motor control exercises on SI joint, sacroiliac joint dysfunction. Let us welcome Professor Sivakumar from India.
Good morning. Here I am going to present paper on to compare the effect of Mulligan's mobilization and motor control exercise on sacroiliac joint dysfunction. Introduction. Mulligan's mobilization has proved to help in regaining the functional movement with application of pain-free accessory glides through passive physiological movements. Motor control exercises are very effective in reducing low back pain. It aims to retain the core muscles of lumbar spine, focusing on the transverse abdominis, lumbar multifidus, pelvic floor to maintain the tonic and atonic contractions. In this study, it was planned to evaluate the effect of Mulligan's mobilization, motor control exercise, and aerobic exercise in patients with SI joint dysfunction. Purpose of the study: Mulligan's mobilization, motor control exercise, and then aerobic exercise are having more effect in this thing. And then this was the spark to compare the effect of Mulligan's mobilization, aerobic exercise, and everything. Objectives of the study: to evaluate the effect of Mulligan's mobilization of pain, functional ability, and muscle endurance. To evaluate the effect of motor control exercise on pain, functional ability, and muscle endurance. Third one is to compare the effect of aerobic exercise on pain, functional ability, and muscle endurance. Null hypothesis: there will be no effect of Mulligan's mobilization on pain, functional ability, muscle endurance, and SI joint dysfunction patients. There will be no effect of motor control exercise on pain, functional ability, and muscle endurance in SI joint dysfunction patients. There will be no effect of aerobic exercise on pain, functional ability, and muscle endurance in SI joint dysfunction patients. And then finally, there will be no significant difference between the effect of Mulligan's mobilization, motor control exercise, and aerobic exercise on pain, functional ability, and endurance in SI joint dysfunction patients. Methodology: study design, randomized control trial. Study setting: Cambridge Institute of Health Sciences. Samples, study sample, simple random sampling. Number of subjects: 95 subjects with SI joint dysfunction. Totally 3 groups. Each group has 30 22 and 33 respectively. Inclusion criteria, history of sacroiliac pain, age limit 16 to 25, gender both male and female students, subjects with 3 to 5 positive tests in sacroiliac joint dysfunction tests. Exclusion criteria, spinal, pelvic and lower limb extremity fractures, radicular pain with neurological deficit, history of spinal surgery, hip or knee dysfunctions, ankylosing spondylitis, rheumatoid arthritis and polyarthritis. And then if you are going for the outcome measures of the thing, one is the pain, functional disability and muscle endurance. Measurement tools, pain is rated by a numerical pain rating scale. Functional ability is by Oswasti disability index, and muscle endurance by pressure biofeedback mechanism. And then if you are taking this methodology, all patients were randomly divided into 3 groups using computer-assisted randomization. Group 1, Mulligan mobilization, 3 sets of mobilization with 5 repetitions was given for 1 week in alternative days. Group 2, motor control exercise, 30 minutes was given in per week. And then group 2, aerobic exercise for 30 minutes. Methodology, group 1, motor control exercises like pelvic bridging exercises, pelvic exercises, knee 2 to 3, 4-point kneeling and pelvic tilting, cobra exercise, plank and crunches. Methodology, aerobic exercise was a form of continuous ground walking at a desirable speed of minimum 30 minutes, 5 days per week was advised. The activities should continue with moderate intensity with less and 150 minutes per week provided by American College of Sports Medicine. And then the result was done by the SPS 20.0 version, and then it was data are analyzed. Significant level was 0.05. And then here the table gives the description about the pain, Oswasti disability scale, and then the transverse abdominis endurance. Okay. Group 1, pre-test and post-test, and then ANOVA, and mean value was given in this first table. And then here, if you are going for the variables, group 1, the standard deviation, and then mean difference was given in the group 1, group 2, and group 3. And then this graph 1 gives a description about the numerical pain rating scale differences in the each group, like movement with mobilization, motor control exercise, and aerobic exercises. Group 2, graph 2 is the Oswasti disability scale. It gives the description about the movement with mobilization, MCE, and then aerobic exercise. Where here you can see the gross improvement in the movement with mobilization over disability index, and then motor control exercise also gives a good significance. And then in aerobics, it doesn't have that much of difference, but slight difference is there comparatively to other 2 groups. And then here transverse abdominis endurance was tested for all the groups, where in the aerobic alone the transverse abdominis endurance was improved compared to the group 1 movement with mobilization and group 2 motor control exercises. Discussion, Mulligan concept of positional fault would seem more applicable in alleviating pain in movement of functional activities. The hypothetical reasons for improvement in the functions may be reduction in the pain source, which aids to improve mobility in the low back and promotes the functions. When functions were normal, the disability would be reduced. Discussion, motor control exercise plays a major role in improvement of cerebrality and control of spinal mechanism in low back pain. It is designed to enhance functions, muscles of lumbopelvic region, and controls the posture. Aerobic exercise also stimulates the release of endorphins, which relieve pain by inhibiting the pain pathway. These exercises would increase the blood flow to muscle and may reduce the stiffness in the low back pain. It also shows the physiological, psychological, and articular benefits in patients with chronic diseases. Discussion, next one. However, all 3 groups show a reduction in pain considerably. Physical activity of all groups would have produced a change in their lifestyle as an additional therapy. And then if you are going for a overall improvement, Mulligan mobilization would produce a remarkable change in both pain and the disability compared to the endurance, muscle endurance. And then if you're going for a conclusion on comparing the all three groups, we have a significant improvement in all things, but comparatively, Mulligan's mobilization with the motor control and the aerobic, we have a good difference in the Mulligan's mobilization on pain, functional ability, and transverse abdominis muscle and health. So we can prefer a Mulligan's mobilization along with the other motor control exercise to improve the muscle endurance, and then to improve the quality of life, we can go for a aerobic exercise. So on conclusion, Mulligan has a good effect on SI joint dysfunction. Limitations and suggestions: limited sample size, baseline fitness level of the participants were considered and then wasn't considered. Long-term efficacy was not assessed. Food activity, lifestyle, sleeping were controlled. Future study can be focused on large samples, long-term studies, and then can also increase the age limit. Okay. Thank you. Thank you very much.
All right. Thank you, Professor Sivakumar, for your presentation. All right. There is no question asked, and since we are running short of time, we will proceed to the next speaker. Hi, our next speaker is Miss Mahadeva Devi Barata. She is from Malaysia. All right. Miss Mahadevi, her topic is effect of PNF, that is proprioceptive neuromuscular facilitation exercises on facial paralysis in children, a systematic review, right? She is from University Tunku Abdul Rahman, Faculty of Medicine and Health Sciences. She is also a senior lecturer, specializes in neurological and geriatric physiotherapy. Okay, let us welcome Miss Mahadevi from University Tunku Abdul Rahman, Selangor, Malaysia. Mahadevi, the floor is yours.
Thank you, Miss Yu. Nice seeing you again. Can you hear me clearly?
Yes.
Okay, thank you.
Clear, right.
Good evening, everyone. So my presentation today is the effect of proprioceptive neuromuscular facilitation exercise on facial paralysis in children, a systematic review. Okay, facial palsy is actually the involvement of the 7 cranial nerves, and it occurs in about 20 out of 100,000 population around the world. And children with facial palsy actually improve quicker than adults with facial palsy. Now, the effects of facial palsy, nerve palsy in children, actually there can be quite significant effects on the child, and it will cause parents a great amount of distress. And it has been well established that there are long-term effects on vision, eating, drinking, psychological issues, self-esteem, and quality of life. So it is therefore important for us to look at the treatment for facial paralysis in children. So mostly the causes are idiopathic. There may be some causes which are anatomical, immunological, like for instance, leading to simple acute bacterial otitis media. And as children are very prone to viral exposure, this adds to the frequency of infectious etiologies as well. And these can be from the HIV, the herpes zoster, and even influenza. Of course, there are neoplasms and trauma as well.
Conference, we are doing a conference. So,
sorry? So the trauma is actually could be from a facial surgery. So diagnosing pediatric facial palsy requires a detailed history collection, and normally it's mandatory to investigate the onset of the parameters and the improvements as well. Okay, now standard management has normally included oral corticosteroids and in a lot of cases physiotherapy as well. Now, physiotherapy in adults with facial palsy has been quite well established with electrical stimulation, exercises, taping, massage, mime therapy, and so on. However, in children, there has been no clinical guidelines whatsoever. Electrical stimulation, of course, is not recommended in the pediatric field, so management tends to focus on exercises as well as massage. Now, studies on adults with facial palsy has used the PNF method to rehabilitate facial palsy. The improvement has been found to be worthy, so it is essential to also try in children and formulate some clinical guidelines. However, there have been very limited studies in this area. So prior to the application of PNF for children, we have thought that it is a good idea to have a literature review to identify the effectiveness of PNF on children with facial palsy. So the study aims to determine the effect of proprioceptive neuromuscular facilitation exercises on facial paralysis in children. So if we conducted our study, we picked out studies from various databases, Google Scholar, ProQuest, Medline, PubMed Central. Okay, and these were some of the search terms that we have included. So our inclusion criteria was that it should be case or case study, any case series, experimental studies, or any RCTs. Studies with PNF as a treatment modality were included, and studies which use one or more assessment tools were included, and we included studies which were published in English. The exclusion criteria were articles we found on blogs or websites, and other treatment modalities that were used, we have excluded those studies as well. So initially, we had 20 articles downloaded on the PNF technique, and after analysis, out of the 20, we found only 2 studies were applicable to the objectives of our research. So all the sources were evaluated, and we looked over the articles to make sure that they met the inclusion criteria. And after gaining the necessary text articles, all the remaining sources were independently screened for eligibility. So the first article that was suitable for this objective was The Correct Smile of a Child by Neuromuscular Facilitation Technique, an interesting case report done in 2017. It was based on a child who was 7 years old, presented with facial palsy. The treatment include facial massage, exercises for the face, PNF exercises, as well as facial exercises, for example, snarling, smiling, frowning, the different sorts of exercises. And this was carried out during for a period of 16 days. And the outcome measure used was the facial grading scale, which has been found to be effective in adults. And what they have found is that they found a documented reduction in the synkinesis. And synkinesis is basically the extra movements, that unwanted movements that occur in facial paralysis. Okay, so the author concluded that facial PNF could have a place in the rehab approach towards facial palsy in children. Now, the second article we found was called Bell's Palsy in Early Childhood, a series of cases. They actually followed 6 cases. And the treatments that were given to the children were basically multivitamins, eye care, PNF exercises, facial muscle exercises. And this was carried out for a duration of 14 days. Outcome measure that was used, again, the House-Bregman scale, which is very commonly used in the facial palsies in adults. So in this case, all the patients actually fully recovered within 4 to 10 weeks, which is also quite common in children with facial palsies. So again, the question remains, is it a natural recovery, or did the treatments play an important part? So from the 6 cases that they found, the authors have said that it can be managed effectively with physiotherapy as well as multivitamins without the use of steroids. So PNF therapy seems to have benefited by stimulating the weakened facial muscles in the principle of irradiation, meaning that other muscles which are being activated, these signals are crossing over to the weakened muscles and therefore stimulate the weakened muscles. So PNF emphasizes the accuracy of the facial movement muscles and improves isolated muscle control. It also prevents the exercises which promote mass contraction of the muscles. So similar studies on PNF for adults have showed that participants who perform self-exercises at home show very much more significant improvements. Neuromuscular facilitation technique aids in facilitating facial muscle activity in functional patterns of facial movement expression. So patterns that we want are stimulated, as well as it suppresses the abnormal muscle activity that interferes with the normal functions. However, we do have a lack of control studies, and mainly this might be because we have very few facial palsies in the pediatric population, and therefore it's difficult for us to collect data. However, we really do need to look at this because there is a population of our children who are getting facial palsies, and there are up to 50% of those who get it have been reported to have residual effects. So in future, further studies would need to be conducted with the aim of formulating clinical guidelines for pediatric facial paralysis. This review supports that PNF exercises may be added to the normal routine management of facial paralysis in children to fasten the facial symmetry. Still, the superiority of the PNF over conventional methods is yet to be concluded. Further studies leading to high quality studies would be needed for maximum benefit. So in conclusion, I would also like to thank my co-author, Dr. B. Arun, and the organizers of the World Conference on Exercise Medicine, the Dean and Faculties of Medicine of Health Sciences, Utah. So thank you very much.
All right, thank you, Ms. Mahadevi, on your interesting presentation. All right, there seems to be no question as well.
Okay.
Just a comment, you know, PNF is actually not easy to do, even for adults, you know. So I was just wondering why PNF was chosen as a form of exercise for facial paralysis for children. Because we all do PNF and we understand, you know, how difficult it is to perform.
Yes, that's true. So PNF in itself, the technique itself has also, shall we say, matured or developed. And there are the principle of irradiation is a principle that we're looking towards. And that's actually activating muscles that are already working and hoping that and they've shown as well that signals will cross over to muscles that are not stimulated. So they've kind of developed their techniques which we can actually use some which are quite natural facial movements, introducing movements and activities for the good side that may be carried over to the weaker side. So that's why, you know, PNF has kind of broadened itself. So yes, that's why we can choose this technique here.
So you're making use of the overflow technique, right?
Yes, that's right with you.
Yeah. Okay. Thank you very much for your answer. And
thank you.
Thank you very much for your presentation again. And we would like to move on to the next speaker. Right. Our next speaker is Dr. Javira Said from Pakistan. And her topic is effect of whole body vibration therapy on holistic muscle in athletes of Pakistan is a randomized controlled trial.
Good evening, everybody. I hope you all are doing great. My name is Dr. Javeria Sayed, and the topic
He's
of
also a lecturer in the Department of Rehab Sciences at the Shifa Tamil Al Milad University in Islamabad. So welcome, Dr. Javeria.
Good evening, everybody. I hope you all are doing great. My name is Dr. Javeria Sayed, and the topic of my presentation today is effect of whole body vibration therapy on flexibility of hamstring muscle in athletes of Pakistan, a randomized controlled trial. Coming towards the introduction, whole body vibration is a topic of interest as evidence suggests. It has an effect on flexibility improvement in athletes. Whole body vibration is a type of machine on which an individual may stand, either sit or lie on the vibrating platform of the machine. The purpose of my study was to examine the effect of whole body vibration on the improvement of flexibility of hamstring muscle among young adult athletes of Islamabad, Pakistan. Now coming towards the methods, a randomized controlled trial from August 2017 to January 2018 was conducted in Pakistan Sports Board, Islamabad. After the IRB approval, a number of 40 athletes that fulfill the inclusion criteria were randomly assigned into two groups, 18 in control and 17 in experimental group through scientific method using convenient sampling technique. Experimental group was given 5 sessions of low amplitude whole body vibration therapy for almost 10 minutes on alternative days and with static stretching of hamstring muscles, and the stretches were 10 stretches total with 15 seconds stretch time and 30 seconds relaxing time, whereas the control group was given only static stretches as per the previous protocol. All participants were assessed using Biodex LIV-MD whole body vibration plate, a goniometer, and a questionnaire. Now talking about the results part, the measures of the data were found to be normally distributed. Resultantly, paired t-test and an independent t-test were used for analysis. When applied paired t-test, the p-value for the experimental group taking whole body vibration sessions was p is equal to 0.00. That makes it a significant value for the range of motion on left and right both sides. But in control group, p-value was 0.42 for the range of motion on left, and it was 0.83 for the right side, which doesn't make it significant one. Further, when independent t-test was applied, pre and post range of motion left hamstring had p-value 0.58, again a non-significant value, and pre and post range of motion on the right side for both groups had value is equivalent to 0.52, again making it a non-significant p-value. So it was concluded that whole body vibrations improved flexibility of the hamstring muscle in athletes within the experimental group, but its additional effects were not significant. Thank you so much for bearing with me. This was all from my presentation. In the end, I would like to thank and greet all the organizing committee of the World Conference on Exercise Medicine for being very cooperative throughout the process. Thank you, Mr. President, and thank you to the whole jury. Thank you to the whole panel. And I hope and pray that everywhere, everybody is all safe and sound. Thank you.
Okay, thank you, Dr. Javeria, for
You're
your
welcome, madam. Thank you so much.
presentation. Right, let's check and see. Okay, is there any question that you would like to pose to Dr. Javiria? Right, there is no question that has been posted. So thank you very much for your presentation.
Thank you so much. Have a great day.
Speaker. Yeah. Thank you. Next speaker, get ready. He is Mr. Chi Yuan Chen from Malaysia. All right, Mr. Chi, his topic is the effectiveness of 6 weeks balance training with perturbation in interaction or whatever, sorry, for in enhancing dynamic balance of basketball players. And this is his thesis for his degree. He is attached to DBC Physiotherapy Malaysia, and he is a sports rehab physiotherapist. Welcome, Mr. Chi Yuan Chen. The floor is yours.
Hello everyone, my name is Chen Zixuan, Sport Rehab Therapist from DBC Physiotherapy Malaysia. My topic today will be about effectiveness of 6 weeks balance training with perturbation intervention on enhancing the dynamic balance of basketball players. For introduction, did you guys know balance is the ability of our body to maintain the center of body mass over the base of support without failing? And for dynamic balance, it's the same ability but during dynamic motions. So what is the perturbation-based balance training mentioned in this study? It's an intervention involving repeated posterior perturbation aiming to improve the control of our rapid balance reaction. And next, the majority of time lost in injuries were due to contact with other players, with the ball holding the most responsibility itself, and followed by contact with opponent or the opposing team players. Most of the injuries occurred within the 3-point line where most of the aggressive contact occurs, while the guard sustained the most injuries, followed by forward and center. This is due to their roles in the game and their playing style. For the problem statement, basketball involves multiple body contact, which when players are unable to stabilize, they get injured. Following that is the limited research regarding the intervention, where most of it focused on older or general population in preventing falls. Furthermore, poor balance itself has been associated with increased injury risk among the athletes. And lastly, the main point. The majority of injuries occurred during contact in games were 67.6, which is not surprising due to the nature of the game itself. For the objective of this study is to identify the balance training with perturbation compared to normal training only on the dynamic balance of basketball players. So you can see right from this picture, it shows the aggressiveness of the contact in the non-contact sport basketball. So for the hypothesis of this study, the first one showed there will be no significant difference between the experimental and control group on their dynamic balance after the intervention. And the alternative hypothesis shows there will be significant difference. And for the second one, the hypothesis null 2, it shows there will be no significant difference between the pre and post for the experimental group after the intervention, while alternative shows there will be significant difference for the pre and post results. So for methodology, here is the sampling. 10 participants recruited by meeting the inclusion and exclusion criteria as you can see here. Active basketball club players attending regular basketball club training 3 times per week, while their age group is around 20 to 25, and they are given all the demographic data and health status questionnaire with the BMI assessment. After that, they were randomly assigned into the EG experimental group and control group. For the intervention, as you can see, measurement tool, I utilized white balance test and training duration, total of 6 weeks, 3 sessions per week and 20 to 30 minutes per session. The rest between set is 1 minute. And the training method for this study, I utilized the perturbation on shoulder level. which is quite common in basketball. Next one is the progression of the stance and the perturbation and the chest pass, and also the rebounding of the basketball. Firstly, the perturbation is varied with different intensity, starting from the constant speed and number which is predictable to the increased speed and number which is more challenging, followed by the random speed and numbers which is unpredictable, which is quite similar to the in-game situation. So this slide is about the version of training method which I mentioned earlier, starting from tendon stand, receiving pass with perturbation, and towards the most advanced unilateral hop, receiving chest pass with perturbation. For the pre and post test measurement, absolute reach in each direction for both legs is obtained, while for the mean dynamic reach in centimeter, the 3 direction is obtained and divided by 3 as there are 3 directions. So here I present the result. For the pre-test value, there is no significant difference between the groups, indicating they are both in the homogeneous group. However, after the intervention, the experimental group showed significant difference in their result. So at the table you can see the mean centimeter reach is 79.44 for the pretest of experimental group, and post-test is around 88.62 centimeters, which is significant. So for this part, it only shows the pre and post for experimental group, which you guys can see clearer of how big the difference is. So for the research finding, this study has shown that the balance training perturbation intervention is effective in improving the dynamic balance of the basketball players. So for the discussion of this study, dynamic balance is improved due to the progressive design of the perturbation variation on different level of intensity. So this different configuration has resulted in the different forms of their physiological stress, and also which in turn induce different types of neural and muscular adaptation. Hence, the finding has demonstrated that proprioception is an important factor in maintaining the balance and sensing the limb position in space. So there are 3 receptors: visual, vestibular, and proprioception, which are very important to maintain the body mass over the base of support after several successful postural perturbation. If one of them are jeopardized, then we'll have some form of challenge or problem in maintaining our body mass. So this is in agreement with DAC and LIMPC, in which the studies they conducted was to train the wushu players on trampoline to alter their proprioception. This intervention has resulted in the superior improvement in the balance ability of the wushu players, because this is due to the repeated sensory feedback and continuous experience to the postural sway. So with that being said, the improvement in the experimental group is also due to the balance in disrupting force imposed by perturbation, because our body is not statically stable even during the bilateral stance, because our central nervous system must constantly make throw and catch pattern adjustment to generate joint torque on both sides of the joint to maintain equilibrium while we stand. So this is in agreement with the studies by Han K et al., which he utilized elastic tubing perturbation to impose an accentuated neural training effect. Following that, it's also shown that minimum of 10 week proprioceptive balance training increases the balance ability and decrease the postural sway of the subjects by 16%, which is a lot. So 6 weeks is also enough or adequate to post the same effect. And lastly, according to Cheng Hizan et al. 2019, postural control is very significant in many sports, and the ability to control the posture may identify successful performance. So, because the ability of an athlete to move their body in a quick and controlled manner within different directions without losing trunk control, it requires good postural stability. So this is in agreement with the study by Combs et al., which proved that improvement in balance ability is a factor in reducing injury risk of basketball athletes and also many other athletes. Lastly, the conclusion. So balance ability is inversely proportional to the risk of sustained low limb injury, and is also important in improving sports performance in athletes, especially basketball players. So these studies have proven to be effective in improving the dynamic balance of the EG. So we can integrate this intervention into the training program of basketball player or other sports or contact sports, because it may help in reducing risk of injuries. So future research, they may include larger sample size, longer intervention period, standard variation, and base of support may be changed to formats to further challenge the ability of the athletes or advanced athletes. And lastly, the intervention variation also may be designed considering to the level of the subject population and to adapt it or adjust it accordingly to their capabilities. So this is the end of my presentation. Thank you. If you have any question, you can ask. And last but not least, special thanks to Sultan Idris Educational University for this approval to use their equipment, laboratory, and also the financial support for publication.
We will move on to the next speaker. Our next speaker is Mr. Shen Ang. Okay, and his topic is retest reliability of Y balance test on dynamic balance among recreational basketball player or another group of basketball players. Degree in sports science, and also he is from Sultan Idris Education University. So welcome, Mr. Shen Ang.
Hi everyone, my name is Ang Shen. I'm a student from Sultan Idris Education University, and my topic today will be retest reliability of Y balance test on dynamic balance among recreational basketball players. Next is the introduction. Balance assessment is a very crucial and important assessment that should be implemented before and after an off-kind of training program, because of how poor ability to maintain balance has been significantly associated with an increased risk of ankle injury. Therefore, the Y balance test was developed to standardize the modified star excursion balance test, which is the SCBT, and the modification is to improve the efficiency in assessing dynamic balance and includes only 3 directions. The Y balance test is also found to be highly reliable and predictive measures of lower extremities injury in high school basketball players. So it is suggested that the Y balance test can be incorporated before physical examinations to identify basketball players who are at increased risk for injury. Moving on to the problem statement, the National Federation of State High School Associations reports that in 1 million students that participated in basketball, nearly 23% of them sustained injuries, and over 65% of these injuries occur in the lower extremities. And one of the main risk factors has been identified as poor balance ability. And because of how basketball players are prone to lower extremity injury, methods to identify those are at an increased risk are needed. Thus, the purpose of this study is to determine the test reliability of YBT so that this test can be confidently used as a measurement tool to assess dynamic balance. Moving on to my research objective and my research question. My objective is to determine the test reliability of Y balance test as a dynamic balance measurement tool among recreational basketball players. And my research question is, does Y balance test have a high test reliability as a measurement tool to evaluate dynamic balance? Next is my methodology, and of course, all subjects were recruited meeting inclusion and exclusion criteria. Convenience sampling method was used, and the age group were 18 to 23 years old recreational basketball players. and a total of 11 subjects were recruited. All the subjects go through the screening process, and below is my demographic data for the research. And moving on to my research procedure. The sampling was 11 recreational basketball players, and they will go through the screening process. And after the screening process, eligible subjects will undergo test session and retest session. And in both sessions, all subjects were allowed to go through 2 practice trials before the real test began, so that the subjects can be familiarized with the test protocols. After the first test session, a 1-week duration would be held before the retest session being conducted. Next, moving on to my results. The findings of test reliability of the use of Y-balance test in measuring dynamic balance is reported using intra-class correlation coefficients ICC with 95% confidence interval. And the table 1 indicated results for left leg stance, while table 2 indicated right leg stance. The ICC results were reported according to the General Guidelines of Potney LG Watkins MP 2009. And according to the guidelines, all 3 directions for both left leg and right leg stance indicated ICC score of over 0.90, which was labeled as excellent. The results of this study indicated that all 3 directions of Y-balance test reveal excellent test-retest reliability. Next, moving on to discussion, and according to Pliski 2006, intra-rater reliability of SCPT has been reported as moderate to good, which suggests the needs to improve the testing method and standardization. The finding of present study also supported by another study by Lee and Ong 2012, reporting that the Y-balance test obtained excellent reliability to be utilized for measuring dynamic balance control for 13 primary school children. The finding of current study also similar to a study by Pliski et al. 2006 that found components of the modified SCBT, which is the Y-balance test, to be reliable and predictive measures of lower extremity injury in high school basketball players. Next, moving on to the implication and application of the study. And due to there is not much to in evaluating dynamic balance, this study further confirmed that YBT is one of the reliable tools for evaluating dynamic balance. And since YBT is very reliable and cheap in comparison to other tools, it can be widely implemented before the game or in a post-injury situation to better confirm the situation of the player before release him or her return to play. However, with the limitation of the current ongoing pandemic situation for this study, the subjects in this study was relatively small. Hence, the further studies can be considered to recruit more subjects to further study the reliability of YBT in a bigger sample size. Moving on to the conclusion. And so in conclusion, the present study indicated that the Y-balance test has excellent test-retest reliability. Therefore, it can be confidently used as a measurement tool on evaluating dynamic balance among recreational basketball players. And these are my references. And that's all for me. Thank you for lending your ears. Any question for me?
Right. There is no question for you, Mr. Ang. Thank you very much for your presentation. We move on. Welcome Ms. Azira Iklima Razali. She is also from Malaysia, and her topic is the effectiveness of dry cupping and hot pack on pain relief for patients with non-specific low back pain. This is her paper for her master's. She is also from Sultan Idris Education University, and she is working as a physiotherapist. So Ms. Azira, the floor is yours.
Assalamualaikum. Hi, how are you today, all of you? Okay, today I will presenting. I'm Azira Iklima binti Razali. I will presenting about the effectiveness of dry cupping and hot pack in pain relief on non-specific low back pain. My topic today will covering about the introduction, methodology, results and discussion, conclusion, and references about my study. Okay, for the introduction, low back pain was the leading cause of disability in high-income countries in almost all Latin America, Asian, and Middle East countries. Usually, low back pain happen because of a few factors such as occupational factors, reduced activity pattern, including wrong sleep pattern, not physically fit, such as wrong lifting method, and psychosocial factor. All of these factors will associate with reduced quality of life, increased work absence, and increased healthcare costs. Okay, about the conceptual framework of my study, low back pain is categorized into acute and chronic pain. Then chronic pain have specific and non-specific. I'm focusing on non-specific. For non-specific, we have medication or surgical and conservative treatment. Within the conservative treatment, there is physical therapy treatment and alternative, such as traditional Chinese medicine. For alternative, it has cupping, and I'm choosing dry cupping representing alternative being compared with physical treatment under therapeutic modalities in thermal, which is hot pack. Okay, let we go to dry cupping first. Okay, what is dry cupping? Dry cupping is about the applying evacuated cups to the skin without bleeding or scarification of the skin. It gives some benefits such as enhanced blood circulation to reduce pain, vascularity, and muscular tensilability. Okay, how it being doing? By applying olive oil on the affected area. 4 glasses of cups were applied to the low back area, and it will be suctioning on that 4 point, and it will be let for 15 minutes. After it removal, it will be wiped with olive oil. Okay, what is the gaps identified from previous study about dry cupping? There is 3 study regarding to dry cupping. Firstly, by Albeda et al. 2015 and Farhadi et al. 2009. It comparing wet cupping with usual care, and the results show that it reduced pain, functional disability, and medication intake within 3 weeks only. And then for the second study, comparing about dry cupping versus placebo control, the results show that it improved pain relief, bone density, and quality of life of nurses among nurses more than placebo control. And the last study is about dry cupping versus control group among postpartum low back pain, and it showed that it is effective in sedation and reduce of pain after postpartum delivery. Okay, for hot pack, what is hot pack? Hot pack was covered on targeted tissue is suitably hot as reported by the patient. Okay, the benefit is increased blood circulation, increased body temperature, and reduced muscle spasm. How it's being doing? By taking hot pack from the hydrocollator and minimum of 6 layers of towels regarding to patient tolerability, and will cover to the low back area, and it will be left for 20 minutes before we remove it. Okay, the gaps identified from previous studies in hot pack was compared with medication, which is paracetamol, ibuprofen, and control group. And the results show that heat wrap therapy is superior to acetaminophen and ibuprofen. The second study is comparing hot pack and gua sha. The results show that gua sha may contribute to pain relief and improve mobility among elderly than hot pack. And the third study, all of the groups have home exercise program, but they comparing between aerobic exercise, hot pack, and TENS and ultrasound, and the third group home exercise program only. And the results show that all are effective to reduce low back pain. Okay, so what is the problem statement? The physiotherapists in Bahrain reported most of their patients will give feedback on their success or failure in managing their low back pain symptom during physiotherapy consultation by using cupping therapy. And they said that cupping therapy is giving benefit to them instead of only physiotherapy session. And the hot pack had been a core usage in physiotherapy practice since the establishment, and it remained in the physiotherapy curriculum. The researcher compared dry cupping with hot pack because both treatments are portable, easily installed even from home, inexpensive and safe. Okay, the objective of this study to compare the effect of dry cupping, hot pack, and control groups in pain management. Either it will relieve the low back pain patient or not. Okay, so we see the next. Okay, the methodology by using randomized control trial, participants are adults from UPSI, Malaysia, and sampling design is purposive sampling. Inclusion criteria more than 18 years old. The patients must have non-specific low back pain at least previous 3 months with NRS reading scale 4/10 minimum. And exclusion criteria it reflects specific causes of low back pain such as sleep disc or sacroiliitis, and regarding to contraindication and open wound on low back pain. Okay. The sample size calculation by using ANOVA, and we use Cohen statistical power analysis. The result show that 13 participants in each group is enough. Okay. For the eligibility for the patients, it will be randomized, and each of group have 13 patients. Pre-test data collection of NRS baseline, and it will be divided into 3 groups. For dry cupping, once only for 3 weeks because of the bruising effect, and hot pack twice a week for 3 weeks. And control group, no intervention, they just continue as previous treatment. And post data test collection on NRS a day after end of intervention. Then we do the data collection and analysis, statistical analysis, and the result of NRS. Okay, so we're using one-way ANOVA. The result will be covering about demographic and NRS, which is pain. Okay, this is the demographic data. For pain relief, it showed that all of 3 groups, control groups, there is no improvement, but dry cupping on hot pack have an improvement in reducing pain intensity. Okay, for dry cupping, before is 6.5, the mean, and it reduced to 3.31. Hot pack 6.08, and it reduced to 3.85. For control group, it increased from 5.95 to 6.15, and there is a significant results after treatment. The p-value is 0.000. Okay, this is the ANOVA reading. And to keep us hot test to identify between 3 groups which is effective. It showed that dry cupping and hot pack more effective than control group in order to relieve pain on non-specific low back pain. Okay. For the discussion, dry cupping session, once a week for 3 weeks to let bruise heal. Dry cupping enhance the circulation of the area surrounding, pain modulation locally, and improving the motion of adjacent joint. That is the reason why dry cupping helping to reduce pain among the non-specific low back pain patient. For hot pack, it prone to thermal therapy on muscle tissue. The immediate vasodilation leads to increased blood flow, which facilitate healing as well as enabling the elongation and increased motion of taut muscles on low back area. So both dry cupping and hot pack have the effect of vasodilation on the capillaries, which help in increasing blood flow and reduce pain level. Okay, so the conclusion as the objective of the study was to compare the effectiveness between the dry cupping and hot pack. It turns out both groups are effective in pain relief on non-specific low back pain. However, dry cupping able to reduce pain more than hot pack clinically, as the changes of pain score from 6 to 3. Moderate group scale to minimal group scale, and both are economical in terms of save time to attend hospital with long queue and more cost effective with non-invasive therapeutic without medication and surgery technique for non-specific low back pain rehabilitation. Okay, this is my references, and thank you for listening.
Thank you, Miss Azira. And there's no question for you. Thank you very much. Okay, our last presenter, right? He is Muhammad Hazif Muhammad Puzi, also from Malaysia. His topic is effectiveness of 6 weeks dynamic balance intervention in handball among adolescent players. Also his thesis for masters, I think. Okay, right. He is also from Sultan Idris Education University. Welcome, Muhammad Hafiz.
Hi, and a very good day to everyone. So, my name is Muhammad Fuzi. So, today I would like to present a paper entitled The Effectiveness of 6 Weeks Dynamic Balance Intervention in Handball Among the Adolescent Players. All right, we go for the first part, which is an introduction. So, basically, this paper is try to find the relationship between the balance and also the performance, and a part of that, how the balance actually help to reduce the injuries among the players, especially the adolescent players. So, in this introduction, I will briefly explain about some of the studies that mention how significant balance towards the performance and also the injuries prevention. First, we look at what Saleh V 2015 mentioned. He mentioned that balance is one of the major effective aspects of appropriate sports skill performance. In different studies, Sugira 2014 mentioned that the ability of the balance is one of the most important physical fitness factors which mainly used while standing and has close relationship with factors such as visual system, vestibular system, somatic sensation, and leg strength. So what Sugiro had mentioned here is the fundamental of the balance itself. Balance is built up from the integration of the visual, vestibular, and somatic sensation, or so-called proprioceptive system. All right. In another different study, Hans J. 2015 has mentioned balance control improvement is one of the most important goals in sports and exercise. All right. Sadari 2013 discuss about the dynamic balance. What is dynamic balance? All right. Dynamic balance is actually the ability to provide body balance while the body is moving. So here we can see that the difference between two types of balance. First is the static balance, and second is this dynamic balance. Static balance is simple to understand when you stand and you are not moving anywhere. That is static balance. You don't have any disturbance or whatsoever that push your body. You just stand still. That is the static balance. Dynamic balance is the balance, the ability of the body to give the postural balance while body is moving. In this case, such as you are walking, you are running, jumping. In the sports case, this balance very challenging because especially for the vigorous type of sports, because they are colliding, running, pushing each other. So this is how actually close relationship between dynamic balance and sports performance and also the injuries, right? So let's get back to what Sadeghi said. Sadeghi 2013 said that dynamic balance is a key component of injury prevention and rehabilitation in sports, and also the dynamic balance causes the center of gravity to move response to muscular activity. Pliski 2006 mentioned that major neuromuscular elements identified that may lead to injury, including the dynamic lower extremity alignment upon landing from a jump, shock attenuation of peak landing forces, muscle recruitment pattern, and also the postural stability or balance. Here we can see there is a relationship between the dynamic alignment and also the postural stability or balance. All right. So moving on next, competitive performance in handball needs the ability to exert force at speed. So here I would like to share to everyone, some of the gestures that needed by the handball players to ensure that they are performing well. So they're required to sprints, to do the rapid acceleration, deceleration, change of direction, jumping on one leg, jumping double leg, forward jumping, vertical jump, and whatsoever. Worst come to worst, they have to collide between the opponent opposing team. So this will lead to injuries if they fall or they have no they don't have a good balance. They will lead themselves to get the injuries. Right, so we can see the facts based on the Oleno et al. 2017. Just there is about 212 injuries in 201 athletes, with ankle and knee being the most affected region. Alright, so this study's purpose, the purpose of this study actually to see the effect, to investigate the effect of dynamic balance intervention, which apply the combination of neuromuscular training, sport-specific movement, coupled with some of the perturbation variation on dynamic balance to see how the effect towards the adolescent handball players. So perturbation actually is the act of doing unexpected disturbance. So some in some studies by Techman 2015, it's mentioned that it can increase the sensitivity of muscle spindles in the muscles that align with the joint, and it will result in higher readiness in responding. So I think this is a good fact that it will help by having a good readiness of the responding from the muscles. It will help the body to reflect well and avoid from any high impact issues on during landing or falling from jumping and any others kind of possible risk on the injuries part. All right, so this is the method on the study. So I'm choosing the quasi-experimenting design with quantitative randomized control trials. So for the sample, about 30 adolescent handball players recruited through the purposive sampling method, which 15 in with the experimental group and another 15 players with the control group. So the measurement tools used for the studies is the star excursion balance test to assess the dynamic balance. Alright, the procedure is about 18 session, 3 session per week, about for duration of 6 weeks. So during this time, the experimental group has undergo the intervention with the dynamic balance intervention, while the control group are doing their normal routine, normal training routine with the supervision. And then the result of the pretest is analyzed through the t-test with the SPSS. So this is the result. We can see there is the significant between pre and the post, and the comparison with the experimental and control group. We can see the difference. So this indicate the improvement on the dynamic balance itself. Alright, so about some conclusion from this study. So I can say the improvement in dynamic balance could be due to the improvement of the visual ability, auditory, vestibular, proprioceptive, and the muscle synergies. As I said in just now, the balance is made up of the visual, vestibular, and also the somatic, or the so-called the proprioceptive system. So the improvement of the dynamic balance could be said as the improvement of these three elements, and also the muscle synergies, because of the reflection has been improved, the improvement of the muscle spindles reflection. So perturbation as the catalyst, yes, it helps to improve the readiness of the muscles. And then by having this injuries rate could be reduced by practicing this kind of training. The injury rates could be reduced Therefore, I would just suggest that this kind of intervention could be considered as a pre-rehabilitation strategies to prevent any injuries, so we can ready the athlete physical, especially the dynamic balance, to cope with the intensity of the sport itself. So that's all for me. Thank you. So we go for the Q&A session.
Thank you, Muhammad Hazif. Right. We have one question from Rajesh Waran Kalai San. How far can we apply general weight training to improve dynamic balance, or specific movement training is important in improving dynamic balance?
All right. Thank you to Mr. Rajesh Warren Kalai Yarsan for the questions. Okay. From my personal experience, to improve the dynamic balance, we need to be specific with the movement instead of having the weight training, because the most important is balance itself. The fundamental of the training itself, we need to focus on the core development first, and then only we can further with the advanced training like weight trainings and whatsoever. Same goes to balance. We need to be specific. If let's say the games is for handball, we need to training the kinds of movement in handball that related with the dynamic balance to be more specific. Then with this intervention, it will help to improve the balance itself. Another part, we can include the weight training by phases according to the adaptation for the athlete itself. If let's say we do for adolescents, so we need to benchmark the level. If we go for the professionals, it's different levels. That's why we need to go for specific training, so it will help to improve the dynamic balance, focusly on the specific movement. I think it's answer the questions. Thank you.
All right, thank you, Rajesh Warren. I hope he has already answered your question. So thank you everybody for listening in for all these abstract presentation. And we hope to see you tomorrow. Okay, log in tomorrow as usual. We will have our more sessions tomorrow. Thank you everybody for listening in. Good evening.
Pick up your feet and don't stop. up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you